ट्रक जी कहाँ है? आ रहे हैं सर, वो बुला रहे हैं। हाँ हाँ बुला रहे हैं सर।
क्या निकाल लो? अच्छा सर्कल लेफ्ट।
ये वाला निकाल दो, ये निकाल दो, ये वाला
Okay, so a very good morning to one and all. So it's a cold winter's early morning, right? Was it easy to reach to the institution? No. Let me say no. Yeah, it is difficult because it's chilly mornings, especially when you are in a city like Jaipur, right? So I also was traveling yesterday from Delhi to Jaipur. So I realized that it's better to reach one day before. I was discussing with sir, because if the fog is like this, then it becomes difficult to reach. Now the difficulty is to come up and open up your minds to listen. I think that is one thing which I feel is very important, and that too somewhere near the weekend when you are reaching, somewhere in between the weekend when you have a chilly morning and principal says you have to come for a CD program. Right? So the attendance has to be 100%, otherwise you will not be there. Correct? So all thanks to you, first of all, because I believe that at the end of the day, no program is successful if you don't have the young minds in it, right? So for today, I am there with you till the afternoon. I'll be sharing my passion, my experience with you, what I had been doing it in my field. Probably it's been almost around 20 years now, right? So that's what we had been doing. So the topic of the day which we have chosen is something which is like we had been looking forward, right? So before I begin, I want to know how many of you are doing an endodontic procedure? Basic endodontics. Root canals. Who all is doing root canals? Okay. And why? And how many interns I have here? Interns. Fantastic. How many postgraduates? Great. So I have postgraduates from all the fields. So one procedure which you will be doing it, and I have my young team who will be doing the endodontic procedure in future, right? So for next 2 hours which we are having on the aspect of endodontic procedure, I would like to cover from basic to the advanced. Those who are sitting at the back, so that they become confident, and those who are in front, they become more confident, right? Because there are a lot of problems what we face in endodontic procedures, and how we can combat, especially when we talk about rotary endodontics. That is what I've been going to share on that. So before I begin, I am actually, today is the media, social media, right? So we are all active on Facebook and LinkedIn and Instagram. I think COVID has made us go stronger on that, right? So the two areas, and I'm blessed that I had been representing India as one of the first gold members in the Excellence in Endodontics group, right? Out of what, more than 1,00,000 endodontics which are there. So I'm the first Indian to win the gold this thing. And along with that, you have a 3D training project. I welcome you all to join both of our organizations. The reason being, what we believe together is that we learn and share together. It's not about only it's all about team. We have a good team working on this. So we would like you to be the part of it. So you can just go onto your Facebook, click on this, and you will be onto that page. Okay. So before we talk about an endodontic procedure, I want to know how many of you play chess? Anybody who plays chess here? The game of chess? No? Start playing. If you have to become a good endodontist. So you'll be like surprised, Prashant sir is talking about a game of chess in the lecture of endo. But why it is so? Can I walk, right? Okay. So why it is so that I am asking to play you chess? What are the things you need when you play chess? You know about chess, right? Or you know only about cricket? Right? Both Virat Kohli is also there, and you have also chess team players. But the thing is, if you have to play a good chess, what is the line that is written? A single move in the right direction can change your life. And that is all about actually about the endodontic procedure. Right? Because if you don't play chess properly, what you will get? Check and mate, you are out of the game. Same thing goes with the endodontic procedure, that every step, what you have to begin. You have to begin that you have to think and then you have to execute. Okay? So this is one thing which is very important. So if you have to become the king or the queen in endodontics, you have to start playing chess. But before playing chess, you need to open up your mind that you need to think before you begin. Like what are the things to be kept in mind in an endodontic procedure before you start, right? So, if we talk about the consideration, like how you will decide that this case I should take up for endodontic procedure, right? The first thing that should come to your mind is how I can do this procedure, or what are the things to be taken care of. Now, if you see here, there are certain things that we need to keep in your mind when you take up any for endodontics. The first thing what you need to look about is the accessibility of the tooth. It's not about doing a procedure. You need to have the access to that tooth that you can do a procedure. Number two is what? Most of the teeth what we get in our endodontics is have lot of caries. Those are posted in endo, right? So you see a carious lesion, right? And then what you do? You say, okay, I have to go for an endodontic procedure. And then you realize after removing all the caries that there is hardly any tooth structure which is left. And then you say, let's refer it to the Department of Oral Surgery for extraction. Now the question comes in, why you didn't decide it before? So the first thing about an endodontic procedure is not a root canal. It's actually that you look at the restorability of the tooth. So first what you should do, you should remove all the carious lesion. And then you should take a call that this tooth can we go for an endodontic procedure? If yes, what is the post-endodontic restoration that you need to plan? That has to be planned before the endodontic procedure. Right? Now that is very important. आपने सारा केस निकाल दिया, पता लगा टूथ स्ट्रक्चर है नहीं, and then you ask a patient to go for a post endor. And patient says, डॉक्टर साहब आपने तो मुझे कॉस्ट इतनी बताई थी. Now why the cost is increased? डॉक्टर साहब पोस्ट लगाना पड़ेगा. पोस्ट की भी कॉस्ट है. So there is always a limitation. So please, the first thing is remove all the carious lesion and access the restorability. Because once you know that you can restore it and what is the restorability, the material you require, whether you require a GIC or you require a composite, so that you have to plan and then you have to think about it. Okay, so that is number one. Number three, which comes is the periodontal status. How many of you have periodontal probes with you? Everybody. But where it is lying? Where? In that UV chamber or into the drawers? Okay, so those who are postgraduate interns, it's not only that you are supposed to use a perio probe only in perio to check the pocket, right? You are also supposed to check a tooth in endodontic procedure that does that tooth has any periodontal involvement, right? Why I'm saying so? My wife is a periodontist. So even if I don't do it, I have to do it. You know, bro. You know? So you can understand, right? So it's always like that. So I'm blessed that my wife is a periodontist. So the value of periodontist, you realize when you marry a periodontist, is not that you need to marry. The question is you need to realize the value of the subject. So check for those pockets because most of the time what we see that the lesions are combined. You did a very nice root canal and then you realize my things are not settling down. So please check for the periodontal status that if they have pockets, if they have bone loss, so you may have to combine your treatment plan accordingly, otherwise you will not get a success. Number four comes, you take a good radiograph. Right? That is the thing that we do. Now once you take a radiograph, you look for the length of the tooth. Right? Now most of the time we use 21 and 25 mm lens instruments. Right? What happens? You open up a tooth, you realize I need 25. The length is too big. So please choose your armamentarium depending upon your radiographs. It's very important, the tooth length so that you open it. Number two, unusual canal shapes. you need to look for the canals. Most of the canals, they look straight, but you also have bayonet shape, you have curved canals. So as we go forward, I will tell you how you can manage those areas. Now, you should also look for extra canals which are there. Now, I have been working in the field of magnification. It's been more than a decade now. It's been more than a decade. And what we have realized that every tooth, they have maximum number of canals. There are more canals because we see well, so we can treat well. So a lot number of canals are there. So MB2s, for example, when you're treating the first molars, about 85 to 90% they do have MB2. The only thing is our mind is focused, teen mil gaya ho gaya. Right? So start looking for that extra canals, and even in lower anteriors, if you talk about, you also get 2 canals. And nowadays the premolars, the most notorious teeth is not a molar, it's a premolar. Because what you think, it never turns out to be that. Right? So make sure that if you start using a little bit of magnification on your eyes in form of loops, I think that will help you to achieve those areas what I'm talking about. Next thing, what you should look for when you take a radiograph of that tooth, you should look for any resorptions which are there. Right? Especially when we talk about young permanent teeth, has a history of trauma, so what you see, there is a resorption of the root apex. And we think, okay, now you need to check for that, and you should realize that which material is ideal. So nowadays we talk about more on the bioceramics like MTA and all, so they are the future, right? Next thing, you should look for what? For the calcifications on the root canal. You took a nice radiograph and you realize half of the canal is visible and half of the canal is patent. Or maybe you see that the whole canal is patent, and maybe you see the whole canal is calcified, right? So the two things which will help you to bypass those areas and help you to combat them will be definitely the magnification and ultrasonic tips. Next, look for canal blockages. Okay, so those are posted in old medicine. You see an X-ray, there is a blockage, okay, or maybe there is a broken instrument, or there is a ledge formation. You see an old root canal which is the obturation is sitting onto the walls but not at the apex. Right? So when you're planning for such kind of treatments, you need to plan your armamentarium accordingly. And last but not the least, perforations. How many of you have done a perforation? Fantastic. I'm busy. Anybody else? Super. Great. Do it. See, if you have not done any complication, you don't know how to manage it. Okay? And this is the time for you to do it when you're in the institution. Right? So that you know that your guides are there, your professors are there to help you out. Okay, this has happened, how you can manage it. Right? So, now, the perforation, if you have done, there are 3 things which is very important. Number 1, the time of perforation. Number 2, the size of perforation. And number 3, the site of perforation. So, what do you think is more important out of the 3? Size, time, or site? Not the time? Suppose you get a radiograph and of a patient who got a perforation done 2 months back, and you open it up, you see a granulation tissue inside. You cannot do anything. So, time of perforation. Now, if the perforation has happened, you should seal it on the same day. Make that habit of doing it, whether it is any kind of a perforation. Right? But if you say, okay, today I did the perforation, I will close it, I will ask the patient to come after 2 weeks, 3 weeks, please don't do that. Okay? So the right materials to seal those perforations are the MTAs and the biodentine. Now, if you have a communication of perforation with the periodontal ligaments, right? Suppose there is a furcation perforation or there is a lateral perforation, the best materials are bioceramics. But if you don't have a communication with the soft tissue, then you can use a GIC or a composite. Okay? So these are the things that you should keep in mind when we talk about an endodontic procedure. Now, next comes is what? To take the good radiograph. Now that is a key. How many radiographs you took, like you take generally when you do any endodontic procedure? How many? 1, 2, 3, 4, 10. जब तक सर समझ नहीं आता लेते रहते हैं. How many radiographs? 2. We talked about 2. Somebody is saying 3. Somebody is saying 1. But minimum 3 radiographs at 3 different angulations is very important when you start a procedure. It's very important. It's not like एक इधर से shoot करा and you say, oh. Okay, so make sure that you have 3 radiographs with the different angulations. Okay, 10 to 20 degree mesial and distal angulation is very important. Now, as we are going to the futuristic approach, there are certain things that we are not able to see on a 2-dimensional radiographs. Right? Now, in such cases, you should know the value of CBCT. That where to advise a 3-dimensional CBCT is very important, right? Now, when we take a preoperative radiograph, what are the things that you actually look for, okay? So if you see here, first you should identify the lesion, the periapical pathology. You should also look for the pulp anatomy, the number of the root canals, okay? You should also look for, as I said, the patent canal or the calcified canal. You should read your radiographs properly, it's very important. Number 4, is there any sinus tract which is there associated in that area? Put a gutta percha point so that you know the offending tooth, right? Sometimes it is in between. So you are like confused which tooth is involved. And last but not the least, the orientation of tooth is very important. 99% where we go wrong during the endodontic procedure is the orientation of tooth. If the tooth is buccally or lingually tilted, you need to tilt your birds accordingly. Otherwise, you will create perforations in your axis design. Okay? So those things are very important to understand. Now, once you have done a 2-dimensional radiograph and things are not clear to you, there is another possibility that you can explore, and that is the CBCT in endodontics, which is changing the perspective what we have been looking at. Right? Now, do you know about CBCT, right? You know this is a CBCT. But have you ever prescribed the CBCT to your patients? Have you ever prescribed the CBCT to your patients? What you wrote on your prescription paper? That's what I want to know.
Only had problems with that, sir.
Sorry?
Only had problems with explaining that.
That's what. See, it's very easy to write advise endo CBCT for tooth number 16. Patient ने पर्चा उठाया CBCT center पहुंच गया. अब जो वहाँ oral medicine is our friend, whomsoever we are sending, he did a CBCT and he says working length is this. Last month clinically correlate. Then why we got the CBCT done? The reason is we as an endodontist or as a dentist should write what we want to see. It's not like endo CBCT advice. No, you have to write what you want to see. Because CBCT can be used for many possibilities. I will tell you what all. So the 3 major possibilities that we look for using the CBCTs, number 1 is identifying any problems which are there. Number 2, assess the complex anatomy of the fused roots. And number 3, we can visualize the bone loss pattern. Do you think it only limits till here? The answer is no. Where all we can use, if you see here, we can use it for any kind of a horizontal and root bulk, like how much is the dentine. Okay. Number 2, for any periradicular lesions, because most of the lesions what we look on a 2-dimensional radiograph looks very small, but because you have only mesiodistal areas to be seen onto the 2-dimensional radiograph. But if you have to really evaluate the periapical lesion, that whether this tooth will go for surgical intervention or non-surgical intervention, you need to have a 3-dimensional. So that buccolingual width you can also see. So you need to write that. Okay. Now you can also write, so see the size and position of the bulk chamber. You can also look for the number of root and root canals. You can write that, they can look for you. If there is MB2 or there is an extra canal or there is a radix case, they will tell you. What type of root curvatures are there? That can also be seen on a CBCT. Okay. Working length determination, and also last but not the least, the canal splitting. You must have faced this experience that you have taken a radiograph and you see after the middle third the canal anatomy is not clear. How many radiographs you take? I am telling you 1, 2, 3, 4. You will not be able to see till you have a CBCT. Because the reason is you need to have a 3-dimensional view to actually understand how you have to start with the procedure. So wherever required, please advise. It's a tool, but finally it's your skill. Because tool plus skill is of a good value. A skill without a tool is of no value. So use just as a tool, but apply your skill accordingly so that you can do a proper diagnosis and then you can execute it. Especially when the cases come to us as an endodontist, they come with lot of expectations, right? When our friends, colleagues send our case, कि Prashant ये करना है. अब करना तो है तो करेंगे कैसे? अगर आधी knowledge होगी. Okay, so you got my point on that. Now, for example, now if you see such kind of cases, when it comes to clinical practice, now this tooth looks very good, which is being treated, upper 6. Isn't it? Looks fantastic. But patient has always a problem. Now what may be the reason? 1 radiograph, 2 radiographs you have taken, what to do? Okay. Now, another very important thing which the fusion we are looking at. Missed canals, right? Another important thing, what happens, you have seen J-shaped lesions, right? J-shaped lesions are vertical fractures. Till date we read and we say J-shaped lesions are vertical fractures, but sorry to say, the thing is, we are all did it till 2-dimensional radiograms. So we used to extract. I am telling you, till the time we as an endodontist are there, I work in such a way, if I tell this tooth has to be saved, then nobody on this earth can take it out. And if I say it has to be extracted, then nobody on this earth can save it. You have to practice that way, if you have to really become confident in your procedure. Now, if you have to say about a J-shaped lesion was a fracture, correct? But that was on the 2-dimensional radiograph. But now, if you see this, this looks like a J-shape, right? It goes like a J. But when you take a CBCT, the lesion is what? The lesion is only a pica. That means the retreatment is possible. So you need to differentiate between this is what it gives you. At the end of the day, if you have to go for an endodontic procedure, what you will do? You will first go for your what? Yeah, CBCT kara lete. Nuksan thodi na. Right? And number two, what you will say your doc when you go and treat? Sir, bachana zarur hai. Abhi nahi nikalna. Sir, jitni koshish ho sakta. Then why we don't apply to the patient when we apply to ourselves? Because patient ne paise dene, humne paise nahi dene. Yeah, we don't care about it. So that is what I'm telling you. You need to be you should to have empathetic to your patients, but with the diagnosis. That's very important, right? So if you see this kind of lesions, definitely it is treatable. So the apical lesion, it is not that vertical. So we can treat that. So we opened it up, located that MB2 canal, placed the calcium hydroxide as an intracanal medicament after the preparation for 2 weeks. And then finally we obturated them with bioceramics. And there you can see that. You can see the second canal which is there, which was there. So all these things you can actually help you to see in CBCT. Another important thing about CBCT what we look for is it tells you about the extent of buccolingual lesions, which you cannot see on a 2-dimensional radiograph. However good you are, if you have to, because endodontics runs on diagnosis. A good diagnosis leads to a good treatment plan, but a poor diagnosis leads to extraction. Okay, so you need to be very careful on that, right? So that you have to take it back. Now, okay, so you did a good, nice one. So you did all the diagnosis. Now the next challenge which comes in endodontic procedure is the local anesthesia. I think that is the first challenge after that. So you gave 1 block, you gave 2 blocks. You keep on giving blocks, right? But patient is like, you put the word and patient jumps. होता नहीं खाली मेरे साथ होता है आपके साथ होता है तो बोलो ना यार होता है इट्स नॉट लाइक इट्स ओनली आपने मेरे साथ तो बहुत होता है पेशेंट को चलता ही रहता है नहीं कहना पड़ता है so you gave 1 block, you gave 2 blocks, right? Now let's see how about local anesthesia if we have to choose it, right? Now the choice of anesthesia depends on the duration of work what you're going to do. So what you have planned for that day? You only plan the access or you plan the entire procedure? Number 1. Number 2, systemic conditions. And number 3, the presence and type of vasoconstrictor. But if you ask me, the most important rescuer in endodontics, when we talk about something like a hot tooth, you must have read about hot tooth, right? You give 1 block, you give 2 blocks, patient is still not cooperative. But you have to open it up that way, right? So in such cases, RTK 4% should be your endo rescuer, right? This is one which has one of the beautiful anesthesia that you can actually incorporate 4% RTK as a block. Okay, now what happens sometimes you have given a block of lignocaine. 1 block you gave, 2 blocks you gave, but patient is still not now. Now you cannot supplement RTK in a block. Please remember that on that day. Please don't do that. You can only supplement RTK as a infiltration. That's it. So make sure that if you have to do it, that only as an infiltration on that day. Otherwise, recall the patient and give a block. RTK block is the best to be actually given. Now, lot of studies, see, because we are in academics also, we do lot of studies, we do lot of research work so that we know that why we talk about RTK. Now, if you see here, after the 7,981 studies which were done, inferior velar nerve block in patient with irreversible pulpitis or mandibular teeth, RTK demonstrated much greater effectiveness in pulpitis than any other drug. And it's true clinically as well. Now, if you see the percentage of chart of specific pulpitis, RTK is 73% more potent than lignocaine. The only thing is it is costly. But I think if you patient, what is more important? The painless anesthesia or the painless treatment, you can just maybe charge 500 more and you are done. It's not that costly as well. 800 में तो पूरा box आ जाता है. Okay, so you should know the value of anesthesia, which one to give at what time. Especially when the patient is having a hot tooth and these kind of conditions, there is a lot of irreversible bite. The patient is not allowing you to touch the tooth. Your RT pen should be the okay. So that you should always keep in mind. Now next comes like okay, so you did everything. Now the patient is numb. Now it's time to enter the tooth. Okay, it's time to enter the tooth. Now, if you have to enter the tooth, you are already entering so many times. I think every day we do one root canal minimum. You open it up, you do some things. Now, as the world is changing, and so we are also changing, right? So you need to change. If you have to go next 5 years ahead of it, you need to add on to your armamentariums somewhere or the other, because today those are sitting at the back, they are young, right? So front, also the front who are sitting there also young. It's not like that we are old. The question is not that. We don't look like, right? That's how exactly it is, because we have to maintain, that's the society is like that. The question is why I'm saying the role of magnification is very important. See, at this point of time, those who are at the back, right? So you are doing your patients, so you make the patient say, upar dekho, niche dekho, daaye dekho, baaye dekho. Okay? But if I come to my colleagues who are sitting in the front, don't you feel that with time we have become little more going down onto that? It will happen, because dentistry is everything is on spine. Okay, so as you grow old, your spine and your ciliary muscles of the eye, they become weak. They have to become weak. Nobody can stop it. Nobody. It's a science, right? So what happens if you are doing a case? So you will be sitting at a distance because your vision is good. But if I ask my seniors, if they are doing a case, nowadays you are bending more to your patients. So like, dekh nira, thoda aur paas jaake dekhna hai. Why? Because the ciliary muscles of your eye, they become weak with time. So we have to adapt to that working distance which is there. So if you have to practice dentistry without specs, right, for long period of time also, with a good ergonomics, then you have to add on a magnification to your practice. Whether in terms of a loop or a microscope, depends on you. Now, this is the first question which I always put. Why everybody says, sir, I don't need magnification. मुझे तो सब दिखता है. अब किसी से पूछो कि आपको सब दिखता है, सब दिखता है. Why should I use magnification? Right? Now, the question is, if you don't use it, choice is with you. How long you want to practice in dentistry, the choice is yours, not mine. Why you took this profession? Why you took? You don't want to practice dentistry, or it was कि BA pass से better है कि 4 साल की BDS कर ले. And nowadays that is there. Why this profession? If I ask you personally, it's not that I am saying. This is one of the best professions you can ever opt for. You have competition in all the professions. It's not only that here. This is what we feel कि dentistry में वो नहीं. But you are wrong. I am telling you. Dentistry is one profession, and this is the only profession which is the best if you ask me. Because here you relieve the pain and you are being paid. The rest you get pain only, you are not paid. So the only thing is you need to become positive to understand the profession. If you don't take it, then why we join dentistry? The only thing is we are a very good beginners, but we are poor finishers. So you need to become a good finisher. जब हम केस शुरू करते हैं, स्टार्ट तो बहुत अच्छा करते हैं, एंड में आते आते we become like चलो भरो. It's like that. Finish, right? So that you should not do. So try to motivate yourself, because I am telling you, patients pay. There is I always tell my students, because I am also teaching, I always say that in any profession there is a scarcity of two things. Every profession has good patients, and every profession has many doctors and many patients. But there is a scarcity of good patients and good doctors. So you need to become good if you have to practice. That is what exactly it is. So that you have to learn the subject. You just cannot say कि ऐसे हो जाएगा, नहीं हो सकता. Okay? So coming to the future, why? That's what I say. Everything starts from the human eye. Your eye is your everything. Okay? Now, when we talk about, have you ever tried, any of you have tried any kind of a magnification devices on your eyes? Loops or a microscopes?
Try.
Try. And what you felt after trying?
Microscope, basically, I've seen through it, one or two cases. Amazing views. But yeah, somebody has to adjust it.
And what about the loops?
Loops are good.
Anybody tried the loops here? But you are using, or you tried and kept it aside?
We have ordered them, we'll get them within a month or two.
Month or two?
So we have ordered from the company.
But you tried before ordering them? Okay. So once they come back to you, then you use it. And then I will ask you that how much headache you are having. Is there anybody who has put a loop on their eyes and then after 5 minutes you said, अब नहीं हो सकता, ये मेरे बस की नहीं. Super. यही चाहिए. I want this answer because this is the 90% problem which is there. It's very easy when you try a loop given by a company and you like just wear it and you say, हाँ बहुत अच्छा लगा, because you are there because for 5 minutes. But as you wear a loop and go on to the patient, that's where the problem starts. सामान तो ले लिया, वापस हो गए, अब क्या करेंगे? So the first thing from where the magnification starts, that you should know which is your dominant eye. Everybody talks about so many things, right? But what is your dominant eye? Do you know? Anybody who says your dominant eye? Left. Okay. So what we can do a small exercise. It will take just 1 minute, 1 second to do it. Okay. So can you see that corner of that wall where this wall is meeting? All of you make like this with the left hand. Okay. Left hand. No, ma'am. You are not. Just listen. Please let me explain. Okay. That's very important. I know you. So slightly you make this circle and put between the center of your both the eyes and keep and watch that area. Do it now. Keep it between the center of both the eyes. Now, okay, don't move your head. Keep it in the center of your nose. This is the nose nasal bridge. Keep it in the center. And now you close one eye, that is the right eye, and you see that this corner is still there or it has gone. Now don't move. Okay, super. Now you close the left eye and then see. Somebody who is able to see with the eye in the center, right or left? How many of you can see with the right? And how many can see with the left? Welcome to the world of magnification. Here you begin. Because your dominant eye is that eye with which you are able to see that area in center. So whenever you start with magnification, whether in terms of loop or a microscope, you have to first see with the dominant eye. If your dominant eye cannot see that thing, your non-dominant eye cannot adjust that. And that is where we fail. That is the reason those who say right, they turn out to be left, those left कहते हैं वो right पे चले जाते हैं most of the time. Because nobody knows that. So nobody knows that. Okay? So you got my point. So now, when you start working with this, you start working in that way. Okay? Now, if we talk about the microscopic concept, it requires 3 things: magnification, illumination, and instrumentations. So, the 2 tools in microscopes or in magnification is what we have. One is a microscope and one is a loop. Okay? Now, if you talk about a loop, what are the things you should take in mind when you choose a loop? This is very important. How you choose a loop? You said you have experienced a loop, but how you choose them? You need to choose your loop properly, isn't it? Now, there are things what you need to keep in mind. Number 1 is the weight of the loop when you go and buy them. Now, weight, how you check? Putting onto that tarazu and measure. How you? Where should you measure? Where you should actually see the weight of the loop? Eyes. Okay. Anybody else? Head. सर पे रख के देखेंगे कितना भारी है. Nasal bridge. You have to wear the loop, and when you put it onto that, you should not feel heavy hair. If your nasal bridge is feeling a weight of a loop, I am telling you, you cannot wear that loop. You can wear it for 5 minutes and you will go into remove it. 100%. Those who are wearing specs, you know better. You are wearing a glasses, where it is light at the nasal bridge. Simple. So the same thing goes ahead with the loops as well, right? Number 2, the magnification power. You need to choose your magnification power depending upon your height and working distance. Okay? Number 3, working distance, as I told, and length and barrel of the loops. Now, it depends on you whether you are a single practitioner or you are a multiple practitioner. Now, if you are a single practitioner who is a loop, then TTL is best, that is through the lens, because you are the only one who will be using it. But if you have like two practice, like two people working at the same center, then it's better to go for flip up and flip down, because then you can adjust your working distance accordingly. And another two important things what you need to look for when you talk about the loop, one is the field of view and one is the depth of field. These are the two things which you should ask the company that what exactly it is. Okay, that is very important. This is my wife, Dr. Meenu. She's a endodontist, so you can see on the slide, right? So a lot of work we do it together on these areas. Now this is a small chart just to help you, all of you out, that how you can decide your working distance depending upon your height. Now if you are less than 5'7", then your working distance when you are sitting is around 34 centimeters. And when you are standing it is around 42. And if your height is between 5'7" to 6'4", then it is 42 and 50. And if you are above 6'4", then it is 50 and 55. So this is just a tentative measurements that you should keep in mind depending upon your height when you go and choose for a loop. So that when you sit on a loop, they give you a magnification which is 2.5, 3.5, 4.5, 5.5. There are many magnifications which are available. So you need to choose your magnification depending upon the procedures what you do more. Right? But an ideal, if you ask me, 2.5 to 3.5 is ideal somewhere which works for every kind of work that you're looking for. Until unless you are going for anything which is too microsurgical. And this is how exactly you see here. Now, whenever you choose a loop, always use a loop with a light source, not with the chair light. अगर आप सोच रहे हैं कि आप chair light से loop पे काम करेंगे, please don't invest your money, don't waste your money in that. If you, because what happens most of the time, we go and buy a loop, light बाद में देखेंगे. If you loop के ले लो. Why we say that you need a light? The chair light is a scattered light, but a loop light is a spotlight. So you need to illuminate the particular tooth what you are working on, right? So that is the reason a loop with light is always recommended. So make sure that when you invest in them properly. Now if you see a little bit of a comparison when we talk about loop and a microscope, so in loop what you get a magnification say about 5x, which is workable. But in microscope you can go up to 20x and more than that. If we talk about illumination, yes, you need some light source with loops, but with microscopes you already have a light. Initially the loops are little cumbersome to use because your neck is not in position. As soon as you go front and back, the whole vision goes up. So that's what I'm saying, that 90% of your cases when you work under magnification, you have to work under indirect vision. Except for upper interiors, rest of the area you will be mostly working under indirect. So that is the reason I say that start the dentistry if you know about the chair positions. पढ़ी थी आपने, apply कभी नहीं करी. If you have to apply it, because if I am telling you, at an age you can do it, but once you cross that age, your back will go, and once the back is gone, you are out of this profession. Dentistry doesn't allow you if your spine is gone. Okay, so make sure that you take care. Again, if we talk about learning, definitely yes, they have a learning curve initially. Expensive, no doubt, loops are a little cheaper than the microscopes, but they don't provide you a variable magnification. So if you talk about microscopes, then definitely you have many variants. This is how I work under my microscope. You can see it is a 6-handed dentistry, generally what we do. 6 to 4, depends on that. So you need your assistant to be also trained accordingly, so that they tell you how to give you the instruments and everything. So it's a bigger chapter to be discussed. So if we talk about magnification, then what exactly we look at? So how you work? Right or left? Because as a dentist, we work not more than 8 to 10 hours in a day. Morning, say about 11 to 2, and evening 5 to 8. And those who are like us academicians, other times the college is right? So let's be really practical. So we have actually working hours for ourselves is not more than 3 or maybe 4 in the evening once you are going back or probably, right? So you want to work for how long? Choices with you. And it gives you a and in under microscopes you can actually work in a very different positions. The best positions to work is between 9 to 12 o'clock positions. Like that is what you need to practice. Once you get into that zone of area, then definitely yes, that you can do that. And it also gives you a good like orientation towards the patient, especially when you're working under the maxillary and the mandibular arch. So if I talk about magnification, I have more than 500 slides to talk about, but I have to just focus on the main areas what I talk about. And definitely your mirrors. Endodontic runs on mirrors and your instruments as well, right? So you need to choose your mirrors wisely. How many of you use mirrors in dentistry? What a question, right? Second question I am talking about. How many scratches are there on your mirror? No, that's very important. How many scratches on your mirrors you have? If you think you have a scratch on your mirror and then you blame the college light is not working, please, I will not accept it. So you make sure that your mirrors should not have scratches. What is glass? It's a sign. We are all science students, right? If you have a scratch on a glass, what happens? It loses the refractive index. So you need to choose your mirrors which reflects 95% light back to you. Especially when we start working more under microscope, you need good mirrors to work. But it's not only one microscope. You need to have your mirrors better. You need to make sure that if you have scratches on your mirror, please remove those mirrors. Don't keep on autoclaving. If you keep on autoclaving them, you will see they become hazy, the glass. And then you can't see anything. Okay, so make sure that we change your mirrors on time. It's not like. And especially when we talk about burrs, if we go under microscope, then our burrs changes from low shank to long shank. That is what exactly, because we have to work under microscopes. Okay, so let's come back to it, because axis design now. So we thought about everything. Now the next step is the axis of the tooth. Now what are the things that we need to keep under the axis, right? So the first thing, if we talk about, most important is the removal of the carious region. That is first, which I have told you, that you remove all the caries before you start with the axis opening of a tooth. Okay. Number two, you need to use rubber dam. That's very important. All caries tooth structure should be removed. And most of the time, if you see, we have proximal caries. 99% cases what we teach in endodontics, they have proximal caries, right? Now, pre-endodontic build-up is very important. It's very important, so that you should do either after the access or after the caries removal. But you should do it before the biomechanical preparation starts. It is the key, because the irrigation protocols, what I am going to tell you, right, and what we had been using will not be successful if you don't have 4 walls of the axis. How will you hold the endodontic irrigant, right? But the most important thing is, how will you apply the rubber dam? How many of you apply actually the rubber dam? Answer is no. So please start, if you are placing a good rubber dam and you are doing the isolation properly, you are the most successful endodontic you will be able to do it. The only thing is, you need to learn it. And it's not that difficult. The only thing is we need to practice. So if you start practicing in college when you have your typodonts and those who are postgraduates, you are doing it, but still, in my department, if there is no rubber dam, they are out. I maybe look very sweet on my face, but I am very notorious as well. That's fact. Can't help it, because when we are teaching, then we are teaching properly. Right? Again, wherever indicated, the tooth should be relieved of occlusion. MDT, that means minimum dentine thickness, you should maintain on the walls of the axis area. That is very important, because if you make the axes too wide with loss of dentine, you will actually lose it. And that is the reason, if you see sometimes when the patient comes back with the crown and open it, the reason is that when you see very wide axes. Nowadays we don't do that wide axes. We do a convenience form. Convenience means that yes, you are able to see all the canals. I am not talking about small axes, truss and ninja. That doesn't work in clinical setup, whether under microscope or anything. Okay, so you need to have that, and you need to ensure that the pulp chamber should be de-roofed completely. That is very important. So this is how you can see the width of the dentine, which is there. At least 1 to 1.5 mm width you should maintain on the cusp. Now, there are different types of burrs that what we had been using in an endodontic procedure, right? Many burrs that you had been using. And most of the time what the burr you are using is what is this kind of a burr, endozine. Isn't it? Round burr with the diamonds. Now, the thing is, when we are doing an axis design, the first radiograph what we always take comes like this. Isn't it? It always comes in an angle. And then like, okay, this is the wall, I have to straighten it out. Now, in such cases, we have to be very careful that we should not touch, in straightening this, we should not touch the floor of the gym. Because if there is a round burr which touches the floor, it will just lead to perforation. So what is the burr which can avoid this, even if it touches the floor? Then that burr is known as M15EZ. It is an M15EZ. It's a carbide burr. It's not a diamond burr. It's a carbide burr. And if you see this burr, this is under my microscope. What you can see, this burr, the tip has no diamonds. So beauty is, like, once you're working with this burr, and by chance it touches the floor, it will not going to cut the floor. So my suggestion is, once you have done the access opening and you want to refine the walls, then this is the burr that you can use. This is the only burr that will help you to be on a safer zone when we talk about the endodontic access defining. Otherwise, you should use ultrasonic tips. They are the best diamond coated ultrasonic tips. So there you can see, this is what I shot just to take some pictures under the microscope so that I can show you how the burrs are. So this is how exactly the flute design of the burr, carbide burr which is there. And here you can see the tip of the burr. It's such a small burr, right? But under a microscope I can see the whole throughout the burr, how exactly it looks like, right? Now you did the access. Now the most important aspect in endodontic procedure is the glide path. A success to the root canal tip is very, very, very important. Let me know.
We'll have to take.
We take it? 2 minutes I'll finish?
Yes, sir.
So we'll take a break. I have to take some 5 minutes break what they're saying. So glide path is the key. Okay? So should we take now? Okay. Should we take now? Okay, so we'll take a break. I think.
Please maintain silence.
सरकार निकाल लो इसको ऐसा निकाल
लैपटॉप दूसरा लगा अच्छा ये ऊपर क्यों आ रहा है?
बस इतना ठीक
ऐसे ही रहेगा।
तो ये इसका नहीं है,
क्या
चार्जर किसका है ये?
अभी वो नहीं
इसका नहीं है मैडम, ये चेंज कर लिए थे हम लोग।
उसका पावर नहीं है
ये भी नहीं है कलर सर, ये नहीं है, ये नहीं है चार्जर। इतना लूज लगता है क्या? लूज लग रहा है मैडम, इसी का है।
वीडियो लगा दिया
हाँ ऑडियो रख दिया मैंने, ये रखा हुआ है,
वहाँ लगा
ऑडियो का दो। इतना लूज है।
हाँ हाँ बसा दो पूरा
Thank you, sir. Thank you, Prashant, sir. Please maintain silence.
Thank you, sir. Your lecture was truly enlightening, and we look forward to resuming the session shortly. But for now, we'll have to proceed with the inauguration ceremony. We are thrilled to witness such enthusiastic participants and a highly learned audience gathered to deepen their understanding of this significant topic. From the year 2000 to 2023, from one college to more than 13 colleges, from a batch of from few students to a family of at least 15,000 existing students and more than 1 lakh students currently. That is NIMS University for us. The vision of a founder and chairperson, Dr. Balveer S. Tomar sir. Recently, in our orientation program, Professor Dr. Balveer S. Tomar sir has launched his book called Unleash Your Inner Power. This book covers the day-to-day challenges we face in our ordinary lives, ranging from time management to stress management, and also a promise to be a good guide. NIMS University has taken a significant step towards global sustainability with the launch of the Global Center for Sustainability Development. This unfolding initiative demonstrates Tomar sir's ambition to bring about positive changes on a global scale. By the United Nations Sustainable Development Goals, the university has positioned itself as a leader in the movement for a supportable future. The aim is to ensure a holistic and inclusive approach to development, leaving no one behind and creating a sustainable future for all. NIMS University has adopted 10 specific goals, which includes no poverty, zero hunger, good health and well-being, quality education, gender equality, clean water and sanitation, affordable and clean energy, industry, innovation and infrastructure, climate action, and life on land. By focusing on these goals, the university wants to make a difference in the lives of people and the planet, promoting prosperity, establishing peace, and building a meaningful relationships. As the doors of our state-of-the-art Dr. B.S. Tomar Cancer and Research Hospital swing open, we proudly embark on a journey of healing and compassion, adding another feather to the institution's cap of excellence, which also symbolizes another significant stride in our mission to serve and uplift the well-being of our community. NIMS Dental College and Hospital was founded in the year 2006 with the goal of providing high-quality dental services to the community by providing exceptional dentistry training to young aspirants with a large team of devoted instructors, impressive infrastructure, modern laboratories. The college has all the latest gadgets, that is, digital radiography, X-rays, dental lasers, dental operating microscopes, computerized RVG, and the latest dental laboratories with all the necessary attachments. The college has a teaching hospital with all specialities of dental surgery, which provides routine diagnostic procedure and treatment like advanced conservative and endodontic treatment, aesthetic dentistry, ceramic crowns and bridges, dental implants, etc. The students are not only given practical training, but also given good exposure through treating raw population as a part of community-based services. The college is accredited by Dental Council of India. It is Rajasthan's first dental college that is accredited by NAC. The college is ranked among top 30 dental colleges of India by Outlook 2019. The dental college upholds the NIMS vision of serving the society and provide the finest quality oral health care to the public by also being regarded as the center of excellence in dental education that places a strong emphasis on the standards, ethics, and culture. The institution's main goal is to provide high quality service to the nation through science and education. Now, before we commence our event, I would invite all the dignitaries, Dr. Sandeep Mishra sir, Vice Chancellor, NIMS University, Dr. M.K. Sunil sir, Principal, NIMS Dental College, Dr. Prashant Bhasin sir, our guest speaker, Dr. Rahul Maria Sir, Professor and Head of the Department, JDC Dental College. And Dr. Nitin Kararia Sir, our Professor and Head of the Department, NIMS Dental College. Thank you, sir. Thank you for gracing us with your presence. Our Honorable Founder and Chairperson, Dr. Professor Balveer S. Tomar Sir, has also conveyed his best wishes to our program. Now, I would like to extend a request to our esteemed Principal, Dr. M.K. Sunil Sir, to kindly step forward and warmly welcome our distinguished guest, Dr. Sandeep Mishra Sir. I would again request our Principal Sir to extend a warm welcome to our second distinguished guest, Dr. Rahul Maria Sir, Professor and Head of the Department of Conservative Dentistry and Endodontics, Jaipur Dental College. Now I would request our Head of the Department, Dr. Nitin Kararia Sir, to kindly welcome our eminent speaker, Dr. Prashant Bhasin Sir. I would now request our Professor, Dr. Shyam Agrawal Sir, to welcome our Honorable Principal, Dr. M.K. Sunil Sir. Quiet, please. May I now request our Professor, Dr. Rachit Mathur Sir, to kindly welcome our Professor and Head of the Department, Dr. Nitin Kararia Sir. Now I request, quiet please. Now I request all the dignitaries on the dais to take the blessings of wonders of knowledge by lighting the lamp of wisdom and give floral tribute to Ma Saraswati. It's not a national anthem, please sit. Maintain silence, please. Thank you. Thank you, everyone. Now, after seeking the blessings, I would respectfully invite our principal, Dr. M.K. Sunil sir, to deliver the welcome address and guide us through the commencement of this program.
A very good morning to one and all. It gives me immense pleasure to welcome you all on this CD program in the subject of conservative and endodontics. I take an opportunity to thank first our chairman sir, Dr. B.S. Thomas sir, who has given a platform to organize such enthusiastic events, particularly in the academic excellence. I welcome our today's guest, our beloved Vice Chancellor sir, Dr. Sandeep Mishra sir, who has accepted our invitation and been here as a part of the guest in our CD program. I welcome you sir, and thanks for accepting our invitation. I welcome the good orator and speaker and well-renowned person in the field of conservative and endodontics, Dr. Prashant Bhasin, who has been traveled all the way from Delhi and accepted our invitation to be part of this CD program. I welcome you, sir, on this occasion. And I welcome our one more guest, Dr. Rahul Maurya, sir, who has been part of this particular CD program, and he has been be a part of a guest to this particular CD program. I welcome you, sir, on this occasion. And the man behind the show, who has done a lot of efforts in organizing. I can see the lot of crowd and the people who have been enthusiastically involved in this particular CD program is none other than Dr. Nitin, the professor and head of the Department of Conservative, and his team, Dr. Sham and Dr. Rachit, put a lot of efforts for the past 1 week, 15 days to organize this program. I welcome you all, and again, I welcome the money team who has supported us in helping of so many things in organizing this particular CD program. So I welcome all the money people who have been there, a part of this program. And the other delegates who have been invited and who have been shown enthusiastic participation in this particular CD program. I welcome all the postgraduates and other delegates to be part of this program. I think definitely this program will enrich you in the academic excellence, and Dr. Prashant definitely will give a justice to share you the better advancements in the field of Rotary Endodontics. Thank you.
Thank you, sir. Thank you so much for the eloquent speech. May I now extend a warm invitation to our esteemed guest, Dr. Sandeep Mishra, sir, to come forward and share his insights with us.
Professor Dr. Sunil, all the dignitaries on the dais, off the dais, and my dear students, good morning to all of you. I welcome you all for this very important meeting, and I am very happy to see a full house and actually people standing, so that is a very good thing. It tells us also one more thing, that we should probably do it at a bigger venue where we can accommodate everybody. But I think congratulations to sir and for getting such enthusiastic response for this very important meeting. I would also like to welcome Dr. Prashant Bhasin, who has come all the way from Delhi to deliver his lecture, and I'm very happy, and I'm sure that all of you will benefit from this lecture. And I can see a lot of budding doctors and those who have already become doctors and are now pursuing post-graduation and so on, and they are in their career, and I wish them all the success in their chosen field of dentistry and further specializations and I'm sure you would do very well in future. You have already seen what is the position of NIMS in the dental fraternity, and you should make use of it, and certainly you will become a very good professional. I'm 100% sure of that. But I think you have to also remember what makes NIMS special. It is not just the professional thing. Actually, you know, you might know, or you might be coming to know this fact that the fields are changing pretty rapidly. Whether it is the field of medicine, dentistry, engineering, any field, whichever you are speaking, is changing rapidly, because we are in the age of information. So this is the age of information where so much information is being added that practically within few years the field changes, and it actually becomes upside down nearly. And likewise the skills also change, and this has started now, and it is progressing very fast. So I have to tell you that whatever skills you learn today, it is possible that after few years they are no longer viable, and some new things have come. So I think beyond mere acquisition of skills, beyond the professional gaining of knowledge and gaining of skills, I think more important thing for you right now, and I thought I should be a vehicle for this information to you, is to change your attitude and to change your behavior. So I think that is even more important than just gaining knowledge and acquiring new skills. And friends, I like to inform you that don't take your focus off these soft skills that you need to pick up, which will change your behavior and which will change your attitude. So what are those skills? One skill is to adapt to change, because change will happen very fast, and if you don't adapt to change, you will remain in the past and very soon will become obsolete, like many things happening. So change is very important thing to incorporate, and that is a skill that you need to pick up. There are many other skills also which you should pick up, particularly being at NIMS or anywhere, actually any educational institution. You have to pick up those skills, because that will make you different from the rest of the crowd. And what are these skills? As I said, one is accepting the change. Most people want to live in structure in their comfort zone, and try to keep in the comfort zone, but that is not going to be sustainable, because things will rapidly change, and if you don't change yourself, you will be in big trouble. So now that option of remaining in comfort zone is no longer existent. That is, I think, number one. The other things that are important is soft skill is communication, and that will change your behavior. The more you grow, the more humble you become. So I think the other advice I can give to you is to be very, very polite and very, very empathic towards your patients, because they have come to you with some trouble. You may not have the trouble, but these people have a trouble, and they not only have a physical, but they have a mental peace also disturbed, and their whole family is also disturbed, and the family is also troubled. So, a very nice word to the family, to the patient, can bring a lot of mental peace to them. And you may not understand it now, but as you grow older and you grow more experienced in your fields, you will realize that a small, word of comfort or empathy towards them will make you a very, very big doctor. So that is the second skill you need to learn, to communicate well and to communicate empathetically. So I think that is the skill that you need to gain, and you should never fight with your patients. I think, because I can see a lot of students, so I would like to say, because a lot of teachers are there already know it, but never fight with your patient. If you have a difference in opinion, very politely state that difference in opinion, and then if it is not striking, keep quiet. Don't ever fight with the patient, because that is, I think, something which will hold you in a good stead all through your life. The other skill I wanted to talk to you about is the skill of resilience. Look, we have come here many of you will be toppers and would have stood first in your class, in your school life, and later on also. But failure is part and parcel of life. Nobody, you give me one successful person and I will show you his failures. There is no successful person on earth who has not failed one time or other. So it is not bad to fail. Fail means not failing in exam merely, but in any project you take, in anything you try to do, you might fail to achieve that particular thing that you set out to. But it is important to accept the failure, learn from it, and move on. Don't keep reminiscing about the failure that this happened bad, maybe because of this person, this thing, that thing. No. Find out why you failed and move on. Go to the next level and accept the failure. So this value of resilience is very, very important in you. So you might do a dental procedure and it may not turn out that nicely. Patient may be very angry with you. So you also try to talk rudely to the patient, and so that will be the worst thing to do. It will be, you should maybe humbly accept and try to improve so that it does not happen the next time. So that is another skill. Third, last thing I would want you to know about is the critical thinking. And critical thinking is not problem solving. Critical thinking is whatever you do, word you say will have a certain outcome. Cause will have a certain effect. Think about what effect can happen with what treatment you have given, with what word you have said, with anything that you do, any action you take will have a certain reaction. So think about this reaction before doing that action. It's like a game of chess. If you move one, piece, then you have moved it, but that will have a certain reaction. So please think of that reaction. And if NIMS is able to teach you these softer skills, besides the professional growth that you have come here for, I'm pretty sure that NIMS has done its work. And we as leaders in this particular university would like to apprise you of these things and learn everything, but with the clear understanding that you cannot hold out on to anything. Nothing in life you can hold on to. You cannot hold on to your own life. So what else you can hold on to? Because at some point of time it will change. So don't hold on to anything. Be there, reach the peak, and move on. I think this is the final thing I would like to say, that reach a peak and then move on. Don't try to remain there and stick to the things, because you will never be able to do that. It's better to move on, and I think you should learn these things. So with this, I think I won't bore you so much with all these things, but I thought, because young minds and we have bit of more experience than you of life, so it is important that we should convey our messages to you so that you don't feel those roadblocks that are going to happen in your way. For everybody it happens. Life is not just victory and happiness. It is a lot of pain and struggles also. So please accept it, and as Gita says, karm kar phal ki chinta mat kar, which means you do your best. Don't think of outcome. If good outcome comes, good. If not, think why bad outcome came and move on. So I think with these words, I welcome you to this very important meeting, and thank you so much for coming and showing so much enthusiasm. And I really congratulate Dr. Sunil and his team for this wonderful effort. Thank you.
Thank you, sir. Your words have truly resonated with us, and we are grateful for the wisdom you shared during your speech. Now it's time to express our gratitude, and for that, I kindly request our principal, Dr. M.K. Sunil, sir, to kindly present a token of appreciation to our honorable guest, Dr. Sandeep Mishra, sir. I again request our principal sir to kindly present this memento to our another distinguished guest, Dr. Rahul Maria sir. Now I request Honorable Sandeep Mishra sir and all the respected dignitaries to kindly step forward and present this token of appreciation to our esteemed guest speaker, Dr. Prashant Bhasin sir, as this will amplify the significance of our gratitude. Now I request our HOD, Dr. Nitin Kararia sir, to present this memento to our respected principal sir, Dr. M.K. Sunil sir. With this memento, we express our heartfelt appreciation for your exceptional contribution and the immeasurable impact you have had on all of us present here. Now, I invite our head of the department, Dr. Nitin Kararia sir, to express a collective gratitude through the vote of thanks. Your words will beautifully encapsulate the spirit of this event and acknowledge the valuable contributions made by everyone.
Good morning, everyone. Good morning, sir. I wish all a very happy new year. Happy New Year, sir. And to see such a crowd, I am truly overwhelmed by the response we have got, both for the on-site and the online mode of the program. Okay. And for extending this opportunity, my first and foremost thanks to our Honorable Chairman and Chancellor, Dr. B.S. Tomar sir, for bestowing upon us this wonderful opportunity. I also convey my heartfelt thanks to our Vice Chancellor, Dr. Sandeep Mishra sir, for sparing his valuable time and coming over to grace this occasion. He also spoke about the soft skills apart from the professional development, and that has been really enlightening for the morning. I thank you, sir, for sparing your valuable time and coming over. Now, no program is ever complete without the collective effort of all the people behind it. So to materialize it, I also extend my thanks to Team Money Medical and especially Dr. Prashant Bhasin for coming over and delivering such a wonderful and comprehensive presentation on understanding of Rotary Endodontics and making it safe and efficient. Thank you, sir, for sparing your time and coming over. My special thanks to our respected principal, Dr. M.K. Sunil sir, who has been a constant source of motivation and support for not only me but for the entire team in making this program to culmination. Thank you, sir, for all your guidance and support. As I move forward in this day, my very special thanks to my colleagues, Dr. Rachit Mathur and Dr. Shyam Agarwal, for their unending and untiring efforts in organizing this program. We have always worked as a team, and we would continue to work as a team to serve our motive of professional and personal development in a better sense. Thank you. And it is really nice for me to see in this morning that we have students from not only our college, but across the colleges of Jaipur. For this, I extend my special thanks to Dr. Rahul Maria sir, who has personally come over and trusted us, sent his students for the program. I also extend my thanks to Dr. Deepak Sharma sir, Principal, Rajasthan Dental College, for sending the students, and Dr. Deepak Rai Singhani sir, Professor and Head, Mahatma Gandhi Dental College, for sending the students. So it is really nice to see that a small effort of doing something in the academic field has responded so well from the colleagues across the fraternity. It is really nice, and I'm totally overwhelmed by this response. Thank you so much. This program is being made possible by the collective efforts of the technology team of the NIMS University and our administrator, Harshita Sharma, for all the logistical and technical support. So I extend my gratitude to them also. And I could see that whatever cooperation I have got for this program has been made possible because of all the different department heads in the faculty of our college. And they have been very, very cooperative in not only arranging for the different requirements for the program, but also helping me in getting the adequate number of registrations and sending in their students. So my sincere thanks to all the department heads and the faculty members present over here. Thank you very much for your cooperation. And now, last but not the least, my very, very special thanks to all my residents for the constant diligence and enthusiasm in making this program a grand success. Thank you very much, all the students. Thank you one and all. I am truly, truly delighted and grateful for your cooperation for this program. Thank you.
So now, as we conclude our event, may I kindly request everyone to rise for the national anthem. Thank you, everyone. Please maintain silence. We'll resume lecture shortly.
हाँ सर लग रहा है अब बस हो गया मेरा हो गया उनका लगा देना लेक्चर वापस से रिकॉर्ड करवा रहे हैं
HDMI.
I think so. We'll proceed for tea break and then we can resume.
As you said. How long is the tea break?
10 minutes to 10 minutes.
You can? Then we'll continue, right?
Yeah, we'll continue with the lecture. Very comfortable.
Very
Call करना मुझे
क्या हुआ? ये वाला स्टार्ट कर
Then we'll.
सभी टीवी रहते स्टार्ट
अब पूछ रहे हैं, यही पूछना अभी दे आर आस्किंग। ये निकाल दो उसको, अगर तो टी ब्रेक लेंगे तो फिर
कोई बात नहीं, रहने दो, कोई चलते रहेगा। चालू है, सुई ऑन कर देंगे, चालू हो जाएगा। लेकिन आप सर दोनों पास में करो तो आवाज़ खराब हो।
जैसे देख लो, वी कैन कंटिन्यू ऑल्सो। You said me how you are comfortable.
Silence, please. It's time for tea break. We'll resume after 10 minutes. So kindly proceed for tea break. I request everyone to report back to LT2 after 10 minutes.
स्पेस नहीं देते जो शेयरिंग से मांगी थी क्या उसका मैसेज अक्षदा की वीडियो भेजो कैसा था अच्छा था मैंने वीडियो बना दी है और मैंने इसीलिए भेज के डिलीट की मेरे फ़ोन से ये दोनों को भेज दिया वीडियो भेजो अक्षदा और तो भेजो भेजो कभी लाड़ में आ जाता है ना
Students वापस आने after 10 minutes, okay? Please report back to LT2.
हेलो कहाँ जा रही है
हमारा सोशल मीडिया है वर्ल्ड वाइड 121 कंट्रीज में ये सब वहाँ जाएंगे इस पर क्या हो जाएगी
आजा 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 अरे आ ना अरे आ जा ना स्क्रब्स में दिखना चाहिए ना पीजी उनको भी इंटर्न्स लग रहे हैं मेरी भी मैं जितने जल्दी हो सके उसको कॉल
यस स्माइल प्लीज थोड़ा सा ऐसे हो जाओ
अच्छा वो आ नहीं रहा होगा
आप इस साइड आ जाओ
हाँ
आपको शेयर करूँगा
जी 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 आपका नाम
लेकिन मैं नया फोन लाया फोटो खींचने के लिए लैपटॉप तो चेंज करा दिया क्या
हाँ हो गया सर प्रशांत सर का लग गया
अरे वो कहाँ है मृदा? दिखी ही ना सुबह से।
लंच के बाद तो अभी इनका लेक्चर कंटिन्यू होगा फिर अपन प्रोसीड करवाना है लंच
तू इतनी नर्वस क्यों हो रही है?
बाबा सब हो गया मेरा बस देरी
इनको कोई टाइम मिल जाएगा अपना सामान अरेंज करने के लिए
हम खरीदेंगे यहाँ से सामान में मिल रहा है टाइम
तू कह रहा है डिस्काउंट फाइनल
होना तो चाहिए फिर आप करेंगे तो शायद प्राइस को
कौन सा प्राइस कुछ भी करती है मैं कहीं क्या करनी
बाद में दिलवा बाद में दिलवा हाँ
तो हमने क्या कांड किया तो देख लो वो पीछे यार YouTube लिंक को पॉज कर दो YouTube लिंक को पॉज कर सकते हैं क्या
सर ये माइक बंद कर दो माइक बंद कर देंगे तो ये माइक बंद कर देंगे
क्या बंद है?
ये वाली माइक बंद करनी है
क्यों तो क्या कर
आवाज़ आ रही है जो भी हम बात कर रहे हैं
यहाँ पे अरे YouTube पे जा रही है YouTube पे
Akshada,
अच्छा ठीक है फिर रहने दीजिए
Akshada, just say that all the you when I say that we will be continuing after a little short.
अच्छा हाँ ओके
We'll be continuing the seminar lecture after 10 minutes.
हमें मत सिखाओ आप जाना।
Hello guys.
इधर देखो इधर देखो।
Here?
थोड़ा स्लाइड की तरफ देखो, स्लाइड की तरफ उंगली करो, हाथ कर लो ना स्लाइड की तरफ।
आगे नहीं करना
नहीं वो नहीं होगा।
मत करो, आ जाओ।
पता चला ले नहीं करने।
माइक तो रहता है। वाह भाई, नहीं वाह भाई वाह।
It's always like when you start driving a car, you always start from the first gear. Okay? So always remember that if you have to learn something, you have to learn from the basic. And the basic starts from the glide path. If you need to spend that time onto the glide path before you jump on any rotary system in the world. It is very important because what happens when you are in hurry, you are always in worry. Okay, so if you don't do a good glide path, you will land up in a lot of troubles in endodontic procedures. So what we have seen in last so many years that we are always in hurry, like jaldi se karte hain aur phir aage badhte hain. No. Endodontic needs two things, patience and persistence. So you need to work patiently in endodontic procedure. Okay. So now why we say that the glide path is very important, right? Glide path is very important because as you enter the root canal, right? And especially when you reach to the apical area after the curvature, you come across many situations depending upon the canal morphology, right? So you are sometimes lucky enough that you get a patent canal, and most of the time you get calcified canals, right? So if we talk about the canals, but yes, when we talk about a glide path, one thing is very important, that when you create a glide path, you should use a small 10 number K file. Now that too when the canal is patent. But generally it doesn't happen until it's a central incisor or a canine or something like that, or maybe a premolar. But as you go towards the molar side, the canals become very narrow, very constricted, right? But the first file should always be a K file. That's what we had been knowing since last so many years. But now the science is changing from K to some other systems as well, depending upon the canal, like whether the canal is calcified or patent. Now, if you have a patent canal, right, so if you see this, you have two canals. One side you see a calcification, other side you see a patency. Now, how you will choose your file? Because if you use a K file in such kind of a canal, what happens? You put a K file and it bends. Most of the time that's what we feel as a clinician, right? So you put a K file, it goes up to the middle third and it's like bent. So you are taking it out, straightening it up, again do watch winding and try to push in, again it bends. And then what you do after 2-3 bends, you need to discard that file. And then you have to open up a new set or maybe a new file of the same 6 or 8 number. Now, if the canal is patent or the canal is calcified, one file which you can use initially when you have to enter the canal, sometimes what we see that the canal is calcified at the orifice. That you are trying to locate that canal, you are not able to do it. So in that cases, you have a solution which is known as a glide finder file. A file which has a cutting tip and it is a dual taper file. It has 2 tapers in one file, especially when we are talking about cutting in that area, because last 3 millimeter the taper is 3%. And from 3 millimeters to up the taper is 2% of the file, and it's a hand file, right? And especially if you see this, especially when you have areas like this, where your file is not going inside the root canal. So you need something which has a cutting. So in that case, you use the file which is a glide finder. Okay, so this is a file which will help you to enter the root canal when it is blocked at the top, right? Again, the motion for a glide path in a hand instrument is always a watch winding. That's it. You are not supposed to rotate a file at 360 degrees. Please don't do that. Sometimes you have a tendency to put a file and you keep rotating as if you are not driving a car inside the root canal. You have to create a glide path, so it has to be slow and along with the EDTA. So make sure that you put a lot of EDT in the root canals when you are doing it. Now, if you have this kind of canal, when there is a lot of calcifications, right, you enter the canal and what happens? Now, if you see here, if you see this radiogram, now you enter the canal and in the middle third you see a calcification and here you see a patency, right? You enter the canal with the K file, what happened? It bended like this. So what is the solution here? When you have something which is calcified in the center, right? When you're not able to go inside, or you have broken an instrument and you have to bypass that instrument. So how will you going to do it? So because every instrument you cannot take it out. You can only take out those instruments which are visible or which you can make it visible. So in such cases, the solution is a D finder. This is the file which is a D finder file which will help you to bypass calcification and also to bypass any broken instrument which is there, right? Now, if you see this file, again, if you see, the cross section of this file is very different from normal K files. If you see here, it's a D finder file. Now, if you see the cross section, and basically it is used for mostly towards the calcified canals or the canals which are a bit curved. In such cases, because you have to first create a glide path with the hand. Because once you create a glide path with hand, then only the rotaries will follow the path. Otherwise, rotary may create their own path, and then if they create their path, it will be always a disaster. Okay. So in such cases, and this is what happens, like if you go with the, if you see this is a K file and a D finder, when you go with the K file, it bends. Now with the D finder, because of the cross section, it is a much more rigid and a stiff file. So you can actually play with this file inside the root canal, right? And if you see here, when you take a K file, it reaches to the calcified area and it keeps bending, and it may lead to a ledge formation. In a calcified canal, the chances of ledge formation are much higher than your normal canals, right? Now in such cases, use D finder, go watch winding, it just goes like a follow the canal anatomy, okay? So make sure, but the motion is watch winding. That you have to keep in mind whenever you are doing a glide path. There is no other motion which is watch winding and push and pull. That's it. Okay, so it's available in various sizes that you can see. Okay, now another thing what comes is when you have a too much of a curvature, especially when you are dealing with lot of curved canals. So what happens? The problem is not this straight part. This curvature is the problem, right? And this curvature can be this way or a bayonet, or so the chances of separation of this file, especially the files, is much higher. So what is the solution for that, right? Most of the time in such cases, what we had been using are the NITI files. That is a nickel titanium, right? But the problem with nickel titanium is that they have a good shape memory, but a poor cutting efficiency. So you keep on struggling into those. So the solution for that is what we say is the RT file. It is the first file ever which is of stainless steel, and it has a good flexibility and a cutting efficiency both together. So especially when we are talking about creating a glide path into a curved canal, then in such cases you can start with these RT files. Now if you see these RT files, they have a very different cross section, and again they are hand files to create a glide path. So this is the RT file that you can see. Basically, when we are talking about curved canals glide path, okay, so that you don't create a ledge there, because in curvatures you create ledges, right? So if you see the cross section, it is very different than that of your normal K files. It has a sharper cutting edge, and the beauty is that it is a stainless steel file. It is not a NITI file, a stainless steel, because stainless steel generally you get more stiffer, right? So if you see this area, then, and the flute design is like that, it pushes the debris more coronally rather than packing it apically, because curved canals, you have tendency to push the debris more apically. So this way, this file can help you to do that. And if you see the flexibility component of this file, it is much higher than that of your K files. So you are actually able to work and get that glide path much more comfortably, especially when you have a curved canal. Because as you reach to the curvature with the K file, you hit the outer wall. You keep on doing it and it creates a ledge. So the solution is what you see is a RT file, especially in those kind of cases where you are dealing with severe curvatures. So first create a glide path with that and then introduce your rotary files. Let me show you a case. If you see this, can you appreciate here? If this is the curvature, this is the RT file. And then followed by the newer files that is desired, what we have used for the preparation. Now, once you have get a glide path, another important aspect in endodontics is the irrigation. I think this is one thing which is I would like to little bit focus more on that as well. Why we say irrigation is important? Because root canals, if you see here, they have very different anatomies. You have lateral canals, you have isthmus, you have accessory canals that you cannot clean with files. Because files only prepare 60 to 70% of the root canal. Rest 30 to 35% root canals, you need to clean them. That's the reason we say it's a chemomechanical. It cannot be a biomechanical. It has to be a chemomechanical. So you have to focus on irrigation. So if you talk about irrigation, one of the very important things in irrigation is what? Which affects the root canal irrigation. What are the things that you need to understand? Number one, the volume of irrigant. Okay, it is very important. Number two, concentration of the irrigant. That what concentration to use. Number three, frequency of irrigation. Number four, the temperature of irrigant. Number five, the length and the time of intracanal contact. That is very important. You need to use irrigant for quite long time. Okay. Then gauge of your irrigating needle. You need to choose your irrigating needle wisely. That which gauge. I will cover it how we go forward. Then the diameter of your prepared canals. How much you should keep the irrigating needle inside the root canal for irrigation, and age of the irrigating solution, because most of the time what we see, the irrigating solutions which are lying in our dental practices are very old. If bottle aapne liye, it's been lying since very long. So again, sodium hypochlorite gets, it turns the color. So make sure that you have to check that. And another important thing is surface tension of the irrigation, so that it has a better penetration into the dentinal tubules. Now if we talk about irrigation in total, what is the irrigation you generally do, right or left? If you are doing this kind of irrigation in your dental practices, please stop doing it. You need to use the needles which are side vented. That is the first needle that you need to understand, that the needle is very important. So the side vented needles comes in various forms. Dual side vented, multiple, but you should have only a side vented needle. And the gauge of the needle is also very important. That what gauge to start with. Because once you go into the canal, the gauge becomes bigger, that is 30. But when you are on the top of the canal, that is in the chamber, then the gauge is 25 or a 27. So that you can put more volume there. And then you need to go inside. So you need to change your gauge from coronal to the radicular part. Okay. Now, this is another, if you see here, this is a small video to showcase you some of the new techniques that what we follow in irrigation, so that you can make your endodontic procedures faster. Now, what you see here, what we have done, we have taken a pulp tissue and put in a dampened dish in a sodium hypochlorite. This is just a needle irrigation we have put it. That's what we do, the irrigation, right? In a root canals, how you do irrigation? You do with needle and a syringe, okay? Now, and what we are doing here, we have put the endodontic irrigant, sodium hypochlorite, and I'm warming the hypochlorite. So what you need to do, if you have to increase the efficacy of your irrigation, you need to warm your hypochlorites. So do you do? No. But you know about it when we did our undergrad or postgrad, that you should warm the hypochlorite. But we never do, because who has time to do? That's the question. Now we should do it. Now the new technique or the new thing, what we have documented and what we have been accepted worldwide and very well is done. Now this is a small video to show with which you can actually warm the hypochlorite within the root canal. So that you can do. That's much easier. If something that you can do within the chamber during your procedure, I think that is the most easiest thing. Rather than I ask you to put it in a something in a hot water bath and it reaches the temperature, because as you do the extra canal walking outside the mouth, as you reach to the tooth, the temperature drops down. So you cannot do it, and secondly it is cumbersome, practically not possible. So the new technique is what? That you fill up the chamber first with the sodium hypochlorite, and then you warm the hypochlorite with a down pack at a temperature of 180 degrees Celsius. So if you're doing lot of obturations, right? So how you cut that obturation, right? So you have that down pack system. So set the temperature at 180 degrees and keep it in the chamber for 10 seconds. And after that, you activate your endodontic irrigant. Because if you are not activating your endodontic irrigant, how good irrigation you do, your canals will not get cleaned. If you think that only needle irrigation will going to clean, those concepts are gone. Because especially when we are doing root canal procedures which are single sitting, or we are doing root canal procedures which are retreatment, endodontic irrigation with intracanal warming and activation is very important. So you need to add on an activator in your armamentarium. That is very important. So are you using any kind of activators? So no. Okay. So, and this is what you can see, the side vented needle. Side vented needle, we are putting the endodontic irrigant, warming it. And then what you need to do inside the root canal is that you have to create an endodontic tsunami. Because most of the pulp tissue which is there attached onto the canal walls, which is unprepared, can only be cleaned with a good irrigation protocol. And that's what our team 3D cleaning group, what you saw, has been working since long time on that. So these are the protocols what we have got. And the best part is that these protocols are clinically done, not in vitro. It's like once you do an in vitro study and then you replicate in vivo, then the results are fantastic. So there you can see that. So what you can use for endodontic irrigation, right? So you have ultrasonics and sonics, right? Now everything has a cost. But to start with somewhere that you can do an activation of an endodontic irrigant, you can use what is a U file. Right? And this U file you can attach with your scalers. With a small tip, you can attach and then you can do the activation of your endodontic irrigant. Because this is more like an ultrasonic activation that you can use it. Now why we say a lot of studies has been done on this, and this is, I'm happy to share, this is our study which is accepted in one of the very impactful journals in the international platform. So this study was done everywhere and then we all collaborated together, and then finally what we got the result, that ultrasonically activated irrigation proceeded by intracanal heated, resulting in significantly cleaner canals compared to only activation or syringe and needle irrigation alone. So the newer concept is that you should warm the hypochlorite and you should do the activation.
So when we are heating the hypochlorite, but we are not putting it inside the canals,
No.
we are just keeping it in the
Chamber. Yes, you will put it in the chamber and then you will put, once you warm it for 10 seconds, you will put the activator. So that will push the endodontic irrigant downstairs inside.
But when we are pushing it, the irrigant inside the canal, then at that time the irrigant which is going, that will be at a normal temperature, that will not be a heated temperature.
See, you have to heat itself inside the root canal as well. So you have to use the tip size accordingly. Okay, so you have to, and you have to keep the tip size 3 mm short. I'm just coming to it. Like, so once you are taking the tip, one is you are warming in the chamber for the volume. And once you go inside the canal, then you have to change the tip. Make sure that the tip should be 3 mm short of your radiographic apex. That is the key. That is very important, because once you put the activation and heating, so once it activates, it pushes the irrigant 3 millimeters ahead of the tip. So for example, if your working length is 18, keep it at 15. Right? So don't take it at the tip. So 3 mm short of your apex, you have to keep that. So a lot of things you need to take care when you are doing an endodontic irrigation, that you can see that it's very important. So rubber dam isolation is very important. Protective eyewear for your patients and for yourself. Because one splash can create a lot of things. If you have not gone through it, so make sure. Okay? Bib to protect the patients, side vented needles which are there, and the Luer lock syringes. So you have some special syringes on which these needles can be put. Okay, so you put into that. And the most important thing, that you should avoid binding the needle into the root canal wall. It's not like you will take the needle, it will bind and then you will push. It has to be free from all the walls and it has to be in an in-out motion. That's very important. It's not like you just keep pushing in, because if you push very hardly, you can take it beyond the periapex area. And once it goes, if you have not gone, those who have gone, they know better. It's a nightmare to handle, right? So, what you things you should keep in mind? So first, you should determine the proper working length and carefully adjust the rubber stopper when you are placing the endodontic irrigant. Okay, number 2, avoid excessive pressure. Constant in and out movement of the irrigation needle is very important. You don't need to keep it just at one point of time and just keep pushing in. And preoperative periapical radiograph to assess the root canal anatomy, so that you can choose the gauge accordingly, right? So the key points, if we talk about endodontic irrigation, that sodium hypochlorite. Now, what is more important, the concentration of hypochlorite or the warming? So even at a low concentration, like 3% if you use, but you warm the hypochlorite, you get the equal results. But please, when you're using these endodontic irrigants, make sure that you are using under rubber dam. Because when the hypochlorite touches the throat, that red areas, if you have not seen, once you will see, that day you will realize and you will tell me. So and that is actually very painful, okay? So make sure that when all the irrigations should and everything, because if you're using non-diluted and this is like diluted like some water, please don't do that. Use at a concentration, a full concentration hypochlorite is very important for the dissolution, okay? Then gauge of the needle, as I said, from the coronal to the radicular we change from 25 to 30. EDTA to dissolve the inorganic tissue. And irrigation activation and internal warming is a perfect DO to actually get the results what you're looking for, right? And the higher the volume and higher contact time will give you the desired results. That is a key. So different phases, what you know is about root canal, that what we have talked about. So again, if we start with the rotary endodontics, the first thing what we look at is you need to do the orifice enlarging, right? That is the first step. Like after the glide path, what you need to do is an orifice opener. Now, to what length the orifice opener should actually go? Okay, so it every depends on that, but according to Grossman, it should be between 3 to 6 millimeter from the orifice. It should go in. That should be minimum that it should go in for the widening. Because why we do, it's a crown down technique, what generally we talk about, right? So you need to do the orifice shaping. Now, secondly, what you need to understand is about the working length determination, like where exactly to stop. Now, to determine the working length, you have many ways to do it, right? So the two ways, now where exactly you should stop? You should stop at the apical constriction. That means now how to measure that working length. Now that is very important. So you have only two methods. One is the radiograph, another is the apex locators, what you had been using, right? Now, when you are talking about these two methods, which one is more reliable? Apex locators, but especially when you have closed apex. But what about those open apex and resorption here? So in those cases, apex locators will not give you that kind of results what we are looking at, right? But certain things that you need to take care when you are using an apex locator, that is very important, okay? So number one is that there should not be any metallic restoration which should come in contact, because it may give you the readings which are very different, okay? Number two, pulp remnants, especially in the root canal specs. Batteries, I think the most common problem what we face is we don't check our batteries, especially if we talk about COVID time, when the batteries were not used, most of the batteries have gone down. So please check your battery that they are charged fully, and once it goes half down, like half is done, you please recharge it, it's always better. Leaking rubber dam. If your rubber dam is leaking or your oral cavity is filled with saliva, you will never get readings. So make sure that rubber dam should be there. And in cases of wide apical teeth with large open apices, you need to be very careful that you are not supposed to use. And when the root canals have excessive fluid, so you need to actually, the canals you have to dry them. So maybe use some paper points, maybe some micro aspirators are also there now, micro suctions are coming, that you can put on your suction tip and you can suck out the maximum liquid which is there in the root canal, okay? So then these things you should keep in mind. Reference point is another important thing that you have to keep in mind, especially when we are talking about any fractured areas or fractured curves. So you need to flatten it up because your reference point should always be reproducible. If it change, suppose you keep it like this, so sometimes you are taking working length here, sometimes here. And please mark my words, every millimeter in endodontics is a kilometer. If you leave 0.5 or you are 1 millimeter short, you are actually 1 kilometer short in a root canal. That's what I always say. And 1 kilometer is a long distance and lot of debris, lot of microorganisms what you leave behind. So please, we work in millimeters, not in kilometers. So when you are in millimeters, you have to be very specific, right? So you need to flatten it up so that this part is always the same when you're taking the working length. Another important thing, when you are measuring your length, how you are doing it on the measuring block, right? Which part you use more? The top one or the side one? Anybody who is using the side ones as well? Stop using it. The reason I tell you why I say millimeter and kilometer, every time you try to put the file inside, your rubber stopper is always tilt, like this. It is never straight. So reference point is always a tilt. So that means you go 0.5 up or you go 0.5 down. So the best part to always use is on the top, because then your rubber stopper is flat. So a flat with reproducible is always better. If you see any tilt in your rubber stopper, please straighten it up. Don't be in hurry, I am telling you again. Endodontic needs, every step is critical, right? You know chess, even your vice chancellor has shown the same thing which I was telling the same morning, right? So play it well. So these are the problems if you don't keep it in mind. What the first problem generally you will be facing is loss of working length. Okay. Number 2, ledge formations. Number 3, zipping. Number 4, stripping. Number 5, either you go beyond or you remain short. Number 6, over preparation if you don't follow it. And last but not the least, which will going to happen is a file breakage. And once a file is broken, and you can understand better than me now. Okay, so it depends on that as well. So what are the things that you can take care to avoid such mistakes? I think that is more important to understand. Number 1, select the clear reference point. Number 2, pre-curve your files. Because please understand, all canals are curved. Even a central incisor has a palatal curvature. What we see on the radiograph is straight, but it's not straight. It has a palatal curve, but it's a two-dimensional. We can't see. Okay, so please make sure. Number 3, you should file all the walls of the root canal. It's not only that you are just working in the center. You need to do circumferential with the hand as well. Always irrigate and recapsulate. This is very important. After every file, you should activate and warm the hypochlorite if you really want to have results which are fast but not furious. Okay, in endodontics you have to be fast but not furious. So you must have watched Fast and Furious, right? How many? 1 to 9, 1 to 10, all you want. So what was the last, what you realized in Fast and Furious movies? You have to be fast but not furious. Eventually he wins. So you need to play well, so that is very important. Okay, check don't rush to the bigger sizes. It's not like that you have to be in a hurry. Step by step. Then check the length of the file after and before insertion. It is very important that once the file goes in and comes out, please see your files, that how much distortion it has gone through. Because if it is going to if it is working under a very curved and a calcified canal, it has gone many of the distortions. So make sure that you discard that file. Otherwise it will break inside the root canal. Okay, discard the files as it showed the deformation, and remove all the previous temporary restorations once you start with the biomechanical preparations. Okay. A clinical situation, I think, which all of you must have gone through while practicing is what? Sir, my file goes to the working length, but my master bone remains short. Most common problem what we face after the preparation. What may be the reason of that? The most common reason then what you have is that why it is happening. See, file is a metal. Gutta percha is a semi-rigid. A metal you put in anything, even in the wall, it will nail in. But try to put gutta percha in the wall. You can't do it, right? So you have created a path. So what is the way to take care of it? So that means the canals are not prepared enough. So again, what you need to do, you need to reinsert the master apical file, okay, until the end reaches to the working length passively. That means you need to recapsulate if there is a lot of debris. And the main problem, what I feel personally, what has been that there is a lack of irrigation, that what we do. Because we are always in a hurry to jump from 10 to 15. 10, 15 karenge, then we'll put a irrigation. No. Endodontics means your irrigation starts from the first step till you finish the last one. It's not, if you jump the files and miss the irrigation, definitely you will go to clog a lot of debris at the apical area. And once it is done, it is, you see, again you are spending that much of time again to recapsulate it. What's the need? Okay. So, if we talk about, now the most important thing in endodontics is how to choose a file. And now there are 100 file systems available, right? So how many of you are using rotary files here? Okay. Many of you are using rotary files, right? So how will you choose a file? What are the criteria for you when you choose a file? What is the first criteria comes in your mind when you go and buy any file system? Sir, root canal kitni hongi isse? What is the first thing that comes to your mind? And if it's a PG, he may be asking, sir, what is the price of the file? See, the both changes, okay? Once you are a postgraduate, your questions are different. And when you are a clinician, your questions are different. And when you are starting, the new generation, when you're going to start, your questions will be very different. Sir, मैं कर भी पाऊँगा कि नहीं? Sir, you are taking a lecture, you are talking about it, but will I able to do it or not? The answer for you, definitely yes. With ease, because that was my topic. Easy and efficient and simple endodontic procedure, right? So to choose your file, you have to have, everybody has different criteria, right? But nobody has a criteria of science. Most of the time, the criteria is cost and the number of canals, right? So I think these are the criteria. That's the reason I listed them. If I talk to my fellow colleagues, so when we talk on the academic front, people talk about ductility, sharpness, cutting efficiency, right? If I talk about ductility, not my choice, right? Efficiency, yes, I need a file which has to be efficient. Cross section, very important, how the cutting will be. How is the flexibility? Does it work in the curved canal? Can I work in all curved canals? right? And last but not the least, how much it will going to cost me. Price is the key, right? But please, at the end of the day, if I start from top to bottom, if I go with the price, and if I go with the quality, and if I go with the solution, that I give you everything in a file system with which you can work with ease, is what? I'll give you a system today, which I will going to introduce you, with which can make your endodontic procedures under all the categories what I told you today, right? But before I tell you that, we need to know about it, that definitely, as we talk about always as team money when we go around, that there are a lot of counterfeit products which are coming in, right? So our sincere request to you that whenever you go and buy any money product, please ask for this. This is very important. Okay, this card, this will help you to check it's a filter, to check whether the product which is coming to your practice is original or duplicate. Okay, so this is a check filter which has been introduced, right? So that is the reason when we always in our lectures show that you should use these filters from where you are buying. Okay, so you ask them to get your filters. So these are the filters for files and these are the filters for birds. So that will help you, because see, you can see many things lying on money, but at the end of the day, you need to see the originality. Okay, so that you do that. Now, before I go to my design, this is my classification to make your endodontic procedure easy. That's what I do in my practice, okay? So I have divided canals in 3 classifications. This is my classification to help you to understand easily. Okay, so either you have a loose canal, or you have a tight canal with a mild curvature, or you have a really tight canal with severe. Tight means calcification, you can take it this way. Now, if you have a loose canal, what is the protocol which generally I follow? Okay, so it depends on the width of the canal, I choose my instrument, the first instrument which binds, okay? So 1502 or a 2502. Depends on if it's a central incisor canal where the canals are bigger. And then I go to my file which is known as a rotary file, which is 1304 rotary glider. Now a rotary file is very important so that you can create a glide path after the manual. It's very important. And then I finish my preparation to 2504 mesials and 2506 distal. That means 2 files and I'm done. Now if it is and I fill. Now if the canal is tight, calcified, then how I go? If it is patent, then I can use a K file because I can get the patency. But if it is calcified, I need to use a combination. So 10 number D finder. Now sometimes what happens when the 10 number reaches to the apex and 15 number doesn't reach. Have you faced this time? Like 10 number reaches to the apex and 15 is like short, say by 2 mm, 1 mm, and you're trying to push. Ledge is there. You will create a ledge. So in such cases, it's better that you go from a 10 to 12 number file. Add on a 12 number, always keep it with you when you see that the canals are very narrow, tight and curved. Because reason being, the jump from 10 to 15 is bigger. But 10 to 12 is smaller. Okay, so use 12 number. Once you get the 12 number in place, you can go with the 1304. Because this is 1202 and this is 1304. Okay, once that is done, then you have to go, if you are, it's a mesial canals, finish 04 preparation. And larger canals finish at 06. Now if you have a canal which is severely tight or severely curved, then what to do? So again, depending upon the canal, 10 number K file or a D finder, whichever suits you. And then 12. Now here, I will suggest you to use a file which is 15 number glide finder. Add on that file there. Because once you start deal with the bigger curvatures, add on that file. Because once you are starting initially, I don't want you to break the instrument. Okay, when you start first, what is the first thing what you want that you should able to do well? Right? Once you become an expert, then you can make plus and minus as per your comfort. But once you are starting with the rotary, always make sure that you follow the way it has to be. Because that will help you to learn the science properly. Okay? So after 15, you can go with the same, how you want to go for it. Okay? That is how you can do that. Now, the newer revolution in the field of endodontics, what we talk about, which will be something, I will say, which will going to change the perspective of Rotary Endodontics. Because the first question to you will be, what are the problems you face in a Rotary Endo? In a file, Rotary Endodontics, what are the problems you face? Think about it. Take 30 seconds. Think about it. The systems what you had been using, what are the problems you have been looking at? You're already using some systems, right? You must be facing some problems. No problems? No? Which one are you? New Endo? Oh, that's fantastic. I know. ब्रेक नहीं होता है तो बताते नहीं, पूछिए तो रहा कि it can fracture. Anything can happen. Anything can happen in the root. Main thing, that's what. Thank you, ma'am, for putting this forward. This is the first thing that is always there when you're working on a rotary system, right? And you always have that question mark behind it, especially because for how long you use that rotary file?
Just one file for only 4.
4 what? 4 canals or 4 molars?
Only in one single canal, the file is used only 4 times.
4 times. But how many root canals you do with that file?
In a single one canal, you can use that file
4 times. But that is you. What about others?
You ask me, that's what I'm saying.
What about others? I'm asking to the general crowd. How many root canals you do? Okay, so I will not go into more details of asking it, rather than I explain you what exactly we look for. Right? Now, what is the meaning of word zizai? That's what we say. It's a newly system. And now the zizai means that you can use at your own will. That is the meaning of word zizai. That's what it has been conceptualized, so that you can use a system which works in 2 ways for you. Number 1 is what? This is the question which I was trying to ask you. How can you trust a recently launched nitride rotary system? That is the reason I was asking you. So I have drafted few questions, which becomes, I think, should be your questions, what I feel. That's the reason I was asking you, right? So these are the list of questions what should be in your mind. If I sit on that side and listen to somebody, this should be my questions. I think this should be your question. Number 1, what is the instrument fracture rate? Your question is there on the right. Number 2, does the shaping ability of this, whatever files I'm going to use, will outperform the current system what is in your hand? Right? Number 3, is the newer system will able to improve my final results in difficult cases? Obviously, I'm a clinician at the end of the day. I need to have a system which works much more comfortably for me.
Should I buy the new
Why?
one?
Why should I buy? If I'm sitting on this side and you're giving a lecture, I will think the same. And that's the reason I put these questions. Does this new system which I'm going to use actually is a technological form depending upon the price, what exactly it is? Number 5, does the newer system shows me better handling properties to make my daily workflow? And most common is, it should be easy. It should be easy. Any system which has to work in endodontic has to be what? Easier. And it has to be technologically driven, so that you know that you can rely on this system before you work, right? So a lot of studies, because postgraduates are there, a lot of studies we have done, right? To compare this system with other systems which are available in the market, right? And we have seen a lot of things, what we came across, right? So we have checked many of the properties of these systems against the already available systems in the market. We have talked about the shaping performance and about their heat treatments, and they are used in single length technique. That is another very important thing, that zizai is used in single length. One go, you go in and you are done. Okay? So a lot of studies, I will not go in detail. These are some of the studies what you can go through. We have been, lot of studies been published on this system already, which you can see here. But some of the features, why we say this system is one of the beautiful systems to work at this point of time when you have a lot of problems coming in rotary endodontics. The first thing which is incorporated in the system is what? Is a radial land. Now you all know about a radial land, I think, right? You must have heard about a radial land. But have you ever saw a radial land? pictures like this only. This is science. Okay? Undergraduates, rake angle, radial land, पढ़ा है ना? पता भी है कि क्या है, पर देखा नहीं. It's time to see. You need to see what you are doing, and you need to believe in a system. Unless you see it, you can't do it. That is what I always believe in that, right? Now, why this radial land is one of the very important feature of ZISAI? Why it is being incorporated? The reason is only one: it prevents the crack propagation of the file in the root canals. It is actually a safety zone which is given in the file so that it gets a good high cyclic fatigue and also a good fatigue resistance, especially when you are working in the canals which are curved. Okay, that is one thing which is very important, right? Because of its entire centering ability, that it keeps the file centered in the root canal system. Number two, the rake angle of this file is negative. Now, the most important problem, what I feel as a clinician, that when we use a rotary file, and as it reaches to the apical area, you feel that somebody is pulling the file inside the root canal. You don't feel it when you are using a rotary file in an apical area. Once you go to the apex, you feel like that somebody is trying, suckling effect, that you feel that the file is getting pushed in. And then you are like, oh, it's go. And there it fractures. Okay. Now, this sucking effect with this file is reduced to almost 80%. That means you can work very comfortably in the root canal system. Number three, the cutting edge of this file is off-centered. It is not in the tip, it is at the side, right? So what happens when the file rotates, and most of the time where the file fractures is beyond the curvature. File never fractures in the straight part of the canal. It always fractures after the curvature into the middle third or the apical area. Most of the time, right? Straight canal, central incisor, any file you work, no problem. Tricky is what? Curved molars or the premolars. Now, because of this off-centered design, the cutting efficiency and the durability of file is very high. Okay? Just to show you is a small video of that. If you see here, थोड़ा slow कर. Now, so this is what you see here is a radial land. Like after every 3 flutes, you will see a flat end into the file. Now, what we have seen in last so many years after comparison, like now if you go back and you open up your RBGs and you take that scale and just check where your instrument is broken. You have that length marking, right? You will see that the most of the instruments fracture between 12 to 14 millimeters in the root canal. So in this file, after every 3 millimeters, you have a radial line. That means a safety 3, 6, 9, 12, 15. That means as soon as it crosses the curvature, it winds, but it doesn't stop there. That is very important. And the chances of ledge formation with the rotary files are much higher otherwise. Now, because of its off-center design, the ledge formation with rotary system is not there. That is what you can see, because it respects the anatomy of the tooth because of the cutting edge which is off-center. So there is like, it doesn't like go and bind and only the file keeps rotating on the top. It rotates completely. Okay. Another important thing if we talk about, it respects the anatomy of the tooth. That's what we have already told you. And if we talk about the basic sequence of this file, what exactly it is. Now generally there are many files which you have to follow. Now the thing is, already you are using files which have 6 files. All of you are using files which have 6. Orifice opener, glide path, 15, 20, 25. Now this file comes with only 3. You need to only need 3 files, right? So what is the protocol you start? You start from number 1, that is the orifice shaper. Okay, that is the first file that you will use. Now, the recommended speed of these files is what? Is 500 RPMs and a torque 3. Don't get worried. Don't get worried. That's what I'm coming up to. The first thing is because we have a habit of 350 and 2.5. Fix them, right? But if I give you something which is at 500 and a torque 3, and with these, You will try it once you do your hands on, right? वो कहते हैं ना पहले इस्तेमाल करें फिर विश्वास करें, something like that. Some ad comes in, right? That's what even I believe in, totally 100%. So the basic sequence, what it goes off, you start with the orifice shaper, and then you have two files as we have discussed for the patency. You have a D finder and a glide finder. D finder you use when you have a calcification. Glide finder when you want to have a patency, patent canal. Now once that is done, you do irrigation, and the next file after this you can directly go to the rotary glider. Now the beauty of this system is that the radial land starts from the orifice shaper and goes up to the finishing files. All files, they have a same design. That means what design talks about is the safety in endodontic procedures. Because what is the priority for me? That the file should prepare, but it should be safe. It should be predictable inside the root canal. Okay? So 1304 is the rotary glider that you will going to use. The recommended speed is somewhere around 300 RPM and a torque is 1. Okay? But you can vary it. You can vary it, you can increase the speed and the torque, not to worry. But this is one of the most important files which will lead to a glide path even in curved canal with ease. That is what we look at. Now once you have done the glide path, irrigation, recapitulation is the part of it. You can finish up your preparation of the mesiobuccals, the canals which are narrow, to 2504, and you're done and you're obturate. So how many files you need? Is only 2. Okay, and if it is a larger canal, for example the palatal or the distal one, you can finish it up to 06. 3504 they also have, depends on your choice if you want to use it. But my clinical practice finishes at 2504 and 2506. Done. But make sure that you do a lot of irrigation. That is the key. That is very important. You need to focus on your irrigation protocol as well. So you need to activate and warm. I think that is much easier to do rather than spending on 6 files. Because more the files, the more the stress. That is also there, right? Which one will fracture, I don't know. Okay? Now how much we need to enlarge the root canals, right? I guess. So, if we talk about, definitely yes, for the narrow canals, now the newer concept says that for the narrow canals, you should not go more than 4%. And 25-4% is minimum that you have to prepare. Because why it is we say 25-4%? Because unless you prepare a good 4%, your irrigation will not reach to the apical area. So minimum 25-04 you have to prepare. Earlier, if you remember, we used to do the preparations which are much bigger. We started from 2, we went to 10. Then we came to 8, and now 04 and there will be a time, so we are going down. Reason being, what is being seen? That if you do a larger preparations, you destroy more dentine of the tooth structure. So once you destroy more dentine of the tooth structure, the fracture resistance of the tooth decreases. So at the end of the day, what the newer concept says is a minimally preparation of dentine. 04 is minimum that we need. Followed by the good irrigation protocol, that is the irrigation, activation and internal warming after every file. And then followed by your obturation for 3-dimensional sealing of the root canal system. So these are some clinical tips. Generally what we say, that you have to start with a crown down approach, what is there. And importance of speed and torque. It's very important because you must be worried about 500 speed and a torque at 3. But once you start using the system with your hand, you will feel, and if you work at a lesser speed with this system, this file will not work for you. Because the thing is, most of us have a tendency to work with lot of active files. We see that debris is coming out, right? And now if you use this file at 350, you will say, sir, this is not a good system. Because you have to follow the manufacturer instruction. And that is the reason the radial land is given as a safety zone. Because at the end of the day, what we look at as a clinician is that we don't want the files to fracture in the root canals. Anything can fracture. But yes, the file gives you an indication that when to discard. The radial land which is given, as that what we saw that after a lot of studies and lot of clinical experience, that 12 to 14 millimeter is the critical zone in the root canal where the 90% of your files. How many of you have postgraduate fractured the file? Where? Middle third or apical third? Answer lies with you. Answer lies with you itself. The question lies with you, the answer lies with you itself. The only thing is we need to as an educator, it's our duty to provide a solution so that we should not land up in a clinical situation which is like a nightmare for us. Okay, so that you need to take care. So always follow the instructions which are being given. It's not like you change the speed and torque as per your, no. With Zizai, 503 is there. You have to keep it if you really want to use the full efficacy of the file to work for you in the root canal system, right? That is very important. This is what you see here. That's what already we have shown, that it has a very low risk of ledge and transportation of the root canal, because I think with the rotary systems what we feel is that, and especially when we talk about too much of a curvatures, lot of variations in the anatomy, that what we see. Now if you have to work in lot of variations, then only you realize the system how predictable it is. Okay, once I go to my clinical cases, when I showcase you, you will see all the variations of vertices what you look at, and we have used the design that very comfortably, right? And a very important and the most important thing, that this is one of the safest file systems even at the body temperature. If you see the comparison what has been there from with Zizai to rest of the systems available, the most safest system at this point of time, especially when you are facing lot of challenges of fracture, or you are facing a challenge of using a rotary system with stress. So you can use this system, just 3 files, and you can do all of your procedure with ease. That is what is more important, because at the end of the day what we look at is a system which has to be comfortable to work on, and definitely we have to have a predictability on the system as well. So before I go to the clinical cases, you can just close it down, the cameras. Now don't go on to the live. Yes, I have already told, right? So if you go on to the clinical cases with Zizai, that you can see that. Now before I go, do you have different kits as per your requirement? Because most of us are here are clinicians also. So maybe you have an Orify shaper with you. So maybe you can add on the other system. So now they have come up with 3 kits as per your use. So postgraduates, you must have some files with you, the Orify shaper, which is long lasting, right? So you can combine the system as you like it, okay? So these are the different kits which are there. Now let's see one by one at a different levels that where we have used design, okay? Now the most notorious teeth in endodontics is fantastic. Everybody's awake. I thought people are sleeping. No? I hope if you're getting sleepy, let me know. Okay. So if you see this case, the first case, this is the lower premolar with a deep split somewhere in the middle third. See, if you have to test anything, test in hard waters. Agar you buy an SUV, take it onto the terrain, then you realize that what exactly the SUV is 4x4, right? And if I'm coming from Delhi to Jaipur, it is no 4x4, it's a straight lane. So I can drive anything which is there, right? But when I have to test in endodontics, I need to go on a terrain. And endodontics is a big terrain, lot of canals, lot of things, lot of anatomies, lot of variations. So let's see one by one. Now, if you see here, now it has a split somewhere at the middle third. So, how comfortable you are with your system in your mind, what you had been using it to work with this. So the first thing what we did, definitely rubber dam, you will see, very important. We have to refine our accesses to see that area well. So again, lot of ultrasonic tips we use. Okay, so when you are doing such kind of refining, you need to use ultrasonic tips which are diamond coated. See, there are 2 types of ultrasonic tips. One are diamond coated, one are non-diamond coated. Diamond coated is basically for troughing. Non-diamond coated is for activation. Okay, now when you buy an ultrasonic tip, my sincere suggestion is, please tell the company which scaler you have. It is very, very, very important. You just cannot say, okay, एक ultrasonic tip भिजवा दीजिए ये वाली. फिर आप पूछेंगे क्रॉस कितनी है, फिर वो टूट जाएगी, फिर आप बोलोगे कि टिप ठीक नहीं है, स्केलर ठीक नहीं है. So always when you are buying an ultrasonic tip, please tell the company what scaler you have and what is the thread design of that scaler. If you have a woodpecker scaler or you have EMS scaler, you need to tell them, I have this scaler, so the thread design of the tip should match the thread design of your scaler. Then only you will get the equal frequency passing to the ultrasonic tip. Otherwise, you spend that money and you will lose the tip very fast. Okay, so that you have to always take care. So what we did, we opened it up, we took the working length, there you can see, and then I used my orifice shaper. After my hand glide path, I use my orifice shaper, the first instrument, and you can appreciate here, somewhere at the middle third, the deep split. Followed by my Zizai glider, what we have used, there you can see the orifice shaper is working at a speed of 500 RPMs and a torque 3. So you can appreciate the two orifice, followed by the 1304. This is what you see under the microscope. When you have a microscope, then you see more deeper and you can document it well. That is the reason I can showcase you that this is where exactly the thing is. We prepared with 1304 and then my preparation ends at 2504. Two files, irrigation, activation, heating will be always there. Okay? And then finally you can see we have obturated these canals with comfortably. How much time it takes? Very less. The more time, the more files, the more stress. What about this? 3 rotated premolars, upper. It's not that you get variations outside India. You get lot of variations in this country. If you see this case, again, an upper premolar with 3 roots. Use of ultrasonics, always I use, because once the access is done, I like to refine my cavity with ultrasonics, because then you have a controlled cutting. If I use a burr here, I can widen it to a very big extent. I don't want to do that, right? This is after the refinement, what you can see. And if you see, the canals are very narrow and constricted. And this is my Zizai. Now you can see this flat end here. Can you see? You can very well appreciate with your eyes when you see the file. After every 3 flutes, you see there is a flat. So 3 flat end, this is the radial line. 6 flat end, 9 flat end, 12 flat end, 15 flat. So that means when you are working in a canals which are very curved, when you are working in an area where you are stressed, Zizai is the solution. Zizai is the solution for you. So that's what we did. And the best thing is they are heat treated file and you can pre-curve it as per the shape before you introduce into the canal. And that's what we did. After 1304, 2504 is my preparation. This is all 2504. Lot of work we keep doing it, we keep publishing, lot of things that you can see here. How about this? MB2s. So again, if you see MB2s, again use of ultrasonics to locate that. Now where is MB2? MB2 is a line joining from the palatal towards the MB1, and that's the MB2 that you can see there. About 80 to 90% of your upper first molars, they do have MB2s. But if you have first knowledge that where exactly it is, that is very important. And second, illumination. And third, where to locate. Now, in such cases can lead to even perforation if you don't locate them properly. So again, thanks to word of magnification, I always say, right? So we dropped it with ultrasonic tips, and there is MB2. Again, step by step, there you can see that MB1, MB2 in place. Lot of irrigation and activation has been done. There you can see that. So I use lot of U files for activation. I can use them. That is the most, I think, the cheapest system available at this point of time to start with activation. Then you can add on as per you, right? So the only thing is what you need to do, you need to just buy an attachment and you have to put your scaler and you can fit this tip. But my sincere suggestion is don't use 15 number a lot initially for yourself. I can use it because it is very fragile. So you start from 20 or 25 that you can use, because the taper of this file is 2%. Okay, so you can take it within the canal, you can activate the and the length is 31 mm. So you can even bend it. So you can just put the stopper 3 mm short, take it, but make sure that it doesn't bind to the canal wall. That is the key. Always keep it in the center and in and out motion, that's all. And then we have prepared with Zizai that you can see that step by step So again, there you can see Zizai in action, and now you can appreciate in this file much more better radial line. So again, 3, 6, 9, 12, 15 and 18 and 21. So you can use in all areas of your canal, and you can prepare your canals accordingly without any canal deformation. That is very important. It maintains the canal anatomy. How about this? Six canals. So what? That's okay. If I only find 3, I cannot sleep. It's like this now. So 6, 3 mesial, 3 distal. There you can see that. 3 mesials and 3 distals. Now such kind of anatomies are not that easy to handle. So that's what I say, go for a terrain, it's always better. Then only you realize the smooth roads. And life is never a smooth road, okay? Life is always a terrain. It goes up and down. So that's what the endodontics is. So you need to go up and down on the terrain. So there you can see step by step after the hand glide path. This is the first file, rotary glider 1304. Followed by the 2504. All 6 canals, 1304 and 2504, done and finished. All gutta perchas in place. Followed by, I use a lot of bioceramics in my practice. It's been 5 years. I love these materials, right? Because it's like something which I use in all my cases from last 5 years. We had been using Cerasil for 2 years, and then for last 3 years I've been using the Safe Endo. So once you have a good preparation of the canal, even your sealer flows well. That is the important thing, right? So there you can see, we have flown the sealer. First we have filled the distal one. Just you need to push in, that's it. And it needs only single cone obturation. That's all. You don't need to put any accessory cones, just you need to fill it. This is the distal, what you see. Step by step, I am flowing and I am putting my GPs. This is for the distal, what you see that. And see here, this is the confluence. I push in and keep a watch here. When your canals are prepared well, is what we always say, your good preparation leads to good sealing. And for that you need to have a good instrument that you can prepare in such kind of canals with these. 2 files and we are done. Irrigation, activation, and followed by the bioceramic flow. And I can fill up those canals much more comfortably. Right? How about this? Okay, broken instrument, ultrasonics. Now this you see the canal. A broken instrument, and this canal is it's so narrow and constricted. Now what to do? Already there is a broken instrument, right? So I use a lot of ultrasonics. There you can see under microscope. I can just focus on the instrument well first, that where exactly the instrument is broken. And it doesn't have only instrument breakage, it also has a perforation. 2-dimensional radiographs are very deceptive. So you need to have a third eye. So what is the third eye? Is the microscope or the magnification, right? So what we did, we used ultrasonic tips. I retrieved that broken instrument. I used a lot of tips in my practice to do that. So you need to use those tips. And there you can see the broken instrument which is there is out. Now, I thought I did a great job. I thought. Okay. But when I opened it up, what I saw, after the removal of that instrument, what you can see here, there was something like a blood coming in. That time it was, because the area was totally covered with instruments, so I don't know. When we removed it, I realized there is some blood which is coming on the side. And this tooth is rotated. Okay, so what we did, and what you see here, this is now the canal from where we have removed the instrument, and this is some perforation which is there. So you need to do that together. So there you can see under the magnification, sometimes the rubber dam, you see here it becomes very difficult when you see the lot of teeth are very treated. So you can see this side is the canal and this is the perforation. Now you see we have tilted the mirror and you can see it is somewhere here, and see the file where exactly it is going. Now perforation, calcification, if I use any system other than design, it will lead to very aggressive cutting and I will destroy more dentine. So what we did, first now the first step is to prepare the canal. So that you know, first you prepare the canal and then you should see the perforation on the same day. That's what I said, okay. So we use design 1304 and 2504 in 2 sequence so that we can prepare to the working length, both in place, so that my one zone is clean. Now, once that is been done, now you can see better. This is the canal and this is the perforation. So what to do? Seal it. So again, I use bioceramic putty in this form. I use lot of putties now, MTA putties which comes from Safe Endo. One program I'll be doing on 11th at Rajasthan Dental College on micro endo and bioceramics which is there. So we'll be talking more on that. So this is what exactly it is, the perforation. So I use a bioceramic putty and I compact it in that area. So it is an MTA in a putty form. That means you don't need to mix it. It's a pre-mixed. Just take it how much you need, put it, and with the paper point, you can just condense in that area. Especially when we talk about the areas of open apex, resorptions, big large periapical lesions where you have to form a 3-dimensional sealing, then putty is a good material to use, and there you can see that. We have sealed that lateral perforation very well. Now what is left is the obturation. Now when you use a bioceramic, add on a bioceramic, it's always better, it gives you a better sealing. Don't use a resin here. I don't use from last 5 years. So what I did, I take my bioceramic, this is bioactive RCS again, and we flow. It's not working. And there you can see that. This is the bioceramic putty and this is the obturation. I don't know why this video is not working. How about this? Another instrument. That was easy, right? Looks on the top. How about this? How many have done this? नहीं किया तो कोई बात नहीं, होता रहता. That was 1, here it is 2. So it happens. It's okay. Even I break. That's okay. We should break it. If you think that every day is a good day, please, it cannot be. I'm a very clear clinician on my working. Right? The day I think it's very good, it becomes very bad on that. Right? So we got this. Again, when we get lot of referrals from your friends, then again the day becomes difficult. Because when they call you and they say, Prashant yaar, ek wo file hai, bas. When they talk very politely on that day, so I feel ki wo file kahan hai, bas ye bata de. Bas, that's the only question I ask him. Rest we'll see how it can be. So he said, ki yaar, aise ho gaya. Now here I am. See, it can happen to anybody. Okay, so please don't criticize your friends and colleagues. Please, please don't. It can happen to you as well, right? The only thing is you need to support your society. It's ho gaya, koi baat nahi. Humse bhi to hota hai. So I said, nothing to worry, send the patient. Patient comes in. So I called him up. एक थी कि 2 थी? बस इतना ही पूछना. या एक ही थी? तो मैंने कहा ये कहाँ से आई? फिर उसने फाइल देखी, यार ये भी हाँ पार्ट तो टूट गया. कोई बात नहीं. I said, okay. Now, if you see here, I have marked this on the RVG to see if this is my situation. My instrument is fractured somewhere at 12 to 14 millimeters here. This is what I am trying to tell you, that you go back to your places, open up your RVGs, whatever instruments you have broken, measure them and you will find this length. So I don't want these fractures to happen for you eventually, because in endodontics we are very confident people, right? But not overconfident. When you go in overconfidence, you lose a battle. Okay, so that's what we did. So first thing is what? To retrieve that instrument. So I used a lot of ultrasonic, as I said, and what you see here are the Teflon tapes which we have blocked rest of the canals. The reason is, in my early days of practice when I started, I was retrieving an instrument, it came out and went into the another. So patient made me only once or twice removal of the same instrument. So please learn. So please block rest of your canals when you are attempting these kind of things. So again we dropped it, removed that instrument first, and then we removed the second also. That is from the distal canal. Now, already the troughing has been done, lot of dentine has been cut. Obviously, when we are troughing, we have to remove the dentine. Now, I have to have a system which is minimally invasive. Ziza is a choice. And that's what we did. I used 2504 for the mesial canals and 2506 for the distal ones. Two files, 1304, 2504, because already the dentine is cut. Why should I cut more dentine? Why? For what? I cannot have a success. Right? Lot of activation, irrigation that you see. And now what you need to see here. Can you appreciate a deep split into the distal canal as well? So, anatomical variations are a lot in endodontics. So, you have to be very clear in your execution. Again, this has been published, that's okay. How about this? Pulp stones, calcifications, right? Let's see. So, this is a case of a lower 7 with 2 pulp stones. Again, step by step, I use ultrasonics. We remove those pulp stones. Again, if you see, the mirrors are very important. A good mirror will give you a good illumination. So we remove the first pulp stone which was there on the top. And then I use my another DG16 to remove the floor. There was a pulp stone on the floor as well. So that we removed it. There you can see that. Big pulp stones, not that small, it's too big. And this is how the floor looks. Looks very beautiful. Only black it looks beautiful, but going inside is not that easy. It's not beautiful, it's very tough. Right? So beauty lies in the eyes of a beholder. That's what is being said. Right? So when I see this, I start appreciating the beauty because I like this beauty a lot. Something which I cannot see. So I have to explore that beauty, right? So that's what we did. So this was 4 canals in the lower 7. Okay, we did the manual glide path, then we did the rotary. I thought I did a great job. This is I thought. On that day it was a tough time for me. When we did that, I realized, I closed it, I sent the patient back. When the patient came to me next time, I was not able to negotiate the canal because I broke something there. So, it's okay. If you know how to manage it, what is endodontics is all about, as I said, patience and the solution you should have. That you can only have if you know the subject well. Otherwise, you are running around in your clinic and patient comes to know from your face that mishap has happened. So either you are smart enough to extract on the same day and send it to your friend for an implant or remove it and place an implant. My wife is a periodontist, I could have done it. नहीं बच नहीं सकता आप इसको निकलवाइए. Okay? Okay, no worries. Again, if you see, that's the instrument, right? We retrieved it again, ultrasonics, troughing. So when you are troughing, we trough mostly towards the inner wall of the root canal so that we can release that instrument. Okay? Because most of the rotary instruments, when they fracture onto the outer wall. Because they are 360-degree rotation. Now, if the files are like that, if they are binding and rotating, then definitely my instrument will go into fracture. And if the instruments are fractured in the top itself, how will I enter the down? Okay, so that's what we did. We retrieved the instruments. Now, though these canals were calcified, now can I take my rotary files directly into these canals if they are calcified? The answer is no. Then you need to understand the value of reciprocation also, a bit of it. Now, in such cases, what I use a reciprocating handpiece. This is a Seco files, again come with money. And I can put it on my handpiece, 10 number, and I created a glide path because it was a calcification. First I use 10 number, and then I use 15 number reciprocation. Okay, Seco files that you can use in reciprocation. Now once I created the glide path with 15 number, now I will start with my 1304 rotary glider. And that's what we did. This is the glider, this is a Zai glider, what you say, it has a 1304 taper. A beautiful system to work with the Zai. if you don't use a glider of 1304, this will not work for you. So you need to use that system. So that the finishing file takes just probably 10 seconds to finish the canal. And this is the sequence what we follow, 2504, all canals. And one I did 30 as well. And then once that is been done, I flow my bioceramics. Now the beauty is just flow it. And you are done with the, who has that much of a time to mix a sealer, to do it and to do it? Flow it and put it and you are done. And you see how the canals are confluent. Once I push the sealer in one, the beauty is that with other sealers, that powder in a liquid system, how much you try to pump, there is always a void which is there. You never get a three-dimensional sealing unless you have a sealer in a flowable form. Right? That is what is being done, and you can appreciate the canal anatomy. All with design, different angulations. How about this? Again, perforation in the location of the lingual canal. Okay, there was a perforation on the floor. Now, such kind of issues do happen with you. And every time when you put a file, it goes into the perforation, not into the canal. Isn't it? You say, okay, this is the canal. You put it and it goes into the perforation. Again, you curve it, you put it, again it goes into the perforation. Till you find the canal. By the time you find the canal, you are frustrated. Let it be here. It's okay. But don't get that. Okay, so what is the solution? How you can manage that, right? So first you should clean the access cavity well. Nicely clean the access cavity so that you know where exactly the perforation is. And put what? You have those gel sponges, that sugar cube which you put in the extraction site. Small gel sponge. This is a beautiful thing that you can actually have. Cut a piece of it and place it there. So it has two roles. One, it is a hemostasis. So there is a lot of bleeding which is happening, it will control. Second, it will help you as a guide path that you know that this is the perforation, I need to put the file somewhere towards the lingual side. That's what we did, right? I placed it there and then I located my canal. Now this file which is there, if you see the lingual canal, it is at the lingual zone, which is the dangerous area of the root canal, right? So I place it there. And then once I have located the canal, I remove that. So what I achieve is a hemostasis here. So it goes step by step. There you can see that. This is a lot of liquid dams what we have put. You can see it right at the different levels of magnification. And then I condense again the gel sponge and then I go with my preparation with design. Because already there is a perforation in the lingual side of the root canal. If I go with a very aggressive system, this what can happen is this part can become attached with that dentine of the floor. It will cut more dentine. So I want some safety to be there. And that's what we did. We used 1304 and 2504. There you can see. And there you can now appreciate. After the preparation, this was the distal. And now you see the mesial. How conservatively it has been prepared with maintaining the interradicular dentine. So no chances of like floor getting weak. Because once the floor is gone, you are gone in the root canal. You are done, you are finished. Now after that we prepared them with design. I used bioceramic, bomb vertical, we flow the bioceramics and everything what we do. Now once that is done, then I go and seal my perforations with MTA. Now this is the map system which I use. So we use different types of systems which are available. So map system is one, it's a very good system. If you want to use it, you can use it. It helps you in the right placement of the material at the right site. And then condense it. Now, in such kind of cases, don't use metal condensers. So the best condenser can be a gutta percha point. You have lot of gutta percha points in your practice, which are like bent and you throw. Don't throw them. They're beautiful condensers. 04, 06, just cut the tape 4 mm from the tape and make it as a condenser. Because it is a semi-rigid. If you put any metal here, you may push the bioceramic into that area. So वो आप डालते ही चले जाओगे, वो जाते ही चला जाएगा. So use, that is what we did. We use a gutta percha, condense it, adapt it, and there you can see. So last two cases before we end this thing. Retic centomolaris, again another case Again, use of Zizai in a sequential form, orifice opener, Zizai glider after the axis. Slowly and steadily you prepare. Lot of irrigation, activation, warming that has been there. And you can see the well prepared all 4 canals. The more horizontal angulations you take, the better you see those canals separately. So in endodontics, there is nothing like this. Everything is horizontal. No mesial, no distal. You have to take many x-rays at different angulations to see the anatomy. C-shaped canals. Again, this is a case of a C-shaped canals. Again, the deep sea. Endodontics is a deep sea. You have to dive in. All canal morphologies you see where you can use Zizai very comfortably. So we have done with Zizai. It has 2 link, one, and this is the floor actually. If you see here, this is the floor. At the different levels of magnification, you can see that. That's it. How you see, well prepared. And then we flow the bioceramics. And finally, you obturate these canals. Last but not the least, you can use Zizai in pediatric dentistry as well. But at a slow speed, not 500, at 350, only in pediatrics. Again, if you see this case where the blunderbuss canals were there, so we have, this is large open apex, large blunderbuss canals, what is there, we opened it up, prepared these canals with Zizai at a slow speed, and then we created an MTA barrier, 5 mm, right? There you can see that with the map system we have prepared the barrier. These are the images that you can see under the magnification. Step by step, pre-op, MTA plug, post-obturation, and this is without a gutta percha. This is whole bioceramic. Because when you have canals, dentine which is very thin, you need to reinforce that tooth structure. So in such cases, we don't use gutta perchas. We do it with, this is an MTA plug with complete bioceramic as one go. And I'm happy to share that this is my case report, which has a 1-year follow-up, has been accepted into the International Journal of Clinical Pediatric Dentistry with the good reviewers and everything that what we have got, and it has given a good follow-up. If you see here, it has led to a good calcific bridge formation. So bioceramics is something which is changing the perspective of endodontics that what we had been doing earlier. So this is how exactly it is. So this was my last case of the day. And again, I am happy to share that we are the first authorized training center for microscopic dentistry in Delhi with Carl Zeiss, Germany. That is how exactly it is. Lot of programs, we keep doing it. And we have done at our centers. These are the group programs, what we do. We also do one-on-one programs. Dr. Rahul sir was one of my candidates that time. He was there at the, and you can, any time when you're visiting to Delhi, you can come and meet us there. And thank you so much, one and all. And thanks for everything. दे दो सब ब्लॉग वगैरह दे दो हाँ वही दे दो एंडो मोटर्स हैंड फाइल्स और रोड Go with the demo now. Yes, sir.
Demo यही करना है। बाहर कल्याण
and these days it's a selfie time. So I need to take one selfie with all of you. So I hope you don't mind, right? No. Let's go for it. Let's go on the phone floor. One more. आ रहे हैं सारे. One more.
मेरा दे दो.
Please maintain silence as we'll proceed for the demo. Please be kindly seated as we are going to proceed for the demo. Please all students kindly be seated as we are going to proceed for the demo.
10-15 जो दे दो.
All those who have registered for hands-on workshop, kindly be seated.
Money, I don't know, but in a clinic, should we use or is it any brand?
Ma'am, see, if you have whatever issues you had been facing with your old files, then this is the solution. Until unless you use it, you will not come to know. तो आप एक बार करके देखो. Where I kept my हाँ नहीं मैंने वो कहाँ रख दिया अपना ये अच्छा ये रहा वही तो हाँ
ये ओरिफाइस यहाँ खुला हुआ है, न्यू पैक ये रहा, अच्छा डिफाइंडर ये
हाँ ठीक है ये नहीं चाहिए नहीं कुछ नहीं चाहिए बस डिफाइंडर छोड़ दो दैट्स इट आई डोंट वांट टू कंफ्यूज डिम्पल इरिगेशन सलाइन वगैरह दो गिव मी द सलाइन एंड इरिगेशन and the endomotor and I'm done. No, yeah, thanks. I'm good.
Actually, I did a very nice job in file breakers. So is there any chance so that I can...
You can retrieve this, yeah. You can retrieve this, but you need to use ultrasonics and everything to do it. Just and under microscope is better to take it out. You have microscopes here? Which one? Which year you are?
Second year.
You are working under that or no? How many you have?
Started working.
So how many you have here?
I did only one case under the line.
Myself, Dr. Sonal Yadav. I am leader in Department of Pediatric Dentistry. I am a pass out of Sudha Rustagi College.
Sudha Rustagi, which
yes,
year?
Sir, I was in 2005 batch. 2005.
You did BDS or
yeah,
BDS?
I did my BDS.
Achha, I joined in 2020 there.
Yes, sir.
Yeah. So it's been
it's
great.
good to know.
Thank you so much. Thank you so much.
Very nice lecture, sir.
Thank you, ma'am. We tried.
Nice
We just try to cover up more on the clinical, that is more important.
So most of the cases you must be working under magnification only, no?
100%.
So like file separations and all, we cannot deal it, I guess, without the magnification.
See, the only thing which are on the top, that you can do it, like how you saw on the orifice somewhere nearby, that you can do. But something which is below the curvature, you need a microscope. Or try to bypass it. So that is what exactly, because retrieval is something which you can only see a file and do it. Without seeing a file, if you just try to, wo perforation ho jayega.
That's why I asked you,
No.
working mostly under microscope.
100%. It's been almost now more than, say, about 12 years now. So it's,
I am a proctodontist actually. So my
Okay.
husband is doing this all. He's using
Rotaries, okay.
So I just want to know that you were using this ultrasonic for the removal.
Yes.
So how they come up with the vibrations only?
Yes, see, you need to trough around the instrument.
Like one of the videos we saw, it just got stick to the tip, like if it's magnetic.
That was, yeah, no. That was non-diamond coated.
Okay.
What you saw.
Okay.
One you see, I was troughing, I was moving around, that has a diamond. So first you trough, so that you create a space, and then you take a non-diamond coated and go and agitate. Then it will come out, it will bounce up.
With the irrigation, without irrigation?
Without irrigation, ma'am. अगर आप irrigation डालोगे तो दिखेगा नहीं ना. वो तो सारा fluid है. तो fluid and file looks the same under microscope. Like you will feel everything is shiny. So that is all. So you should put that file, put irrigation, suck that out, and then that area should be dry. And so that you know that this is the inner wall, this is the outer wall, there you are supposed to draw. So it's a very, very, very precise.
And glide path you are using at 300 RPM. Glide path
301. You can use at 400 and 500 as well, not to worry. It depends on if you have a canal which is curved, then maybe you have to use at 350 or 400. Then 300 doesn't work that better, so increase the speed, no problem.
So you are basically in Delhi only?
I'm Delhi based, totally. Born, brought up, family, everything. I'm Delhi. I'm PG from SDM Dharwad. Postgraduate from there. Yeah. Thank you so much, ma'am. Thank you.
So you're conducting courses also?
Yeah, we do one on. See, we have a 3 days of a program where we talk about rotary, irrigation, activation, internal warming, everything is there. You can just take my number, so I'll WhatsApp you the details.
This program is Delhi only?
Yeah, Delhi, at our center. It's a 3 days. It's on weekends mostly, depending on the one-on-one. We generally do mostly one-on-one.
Okay.
So where we have like 2 participants, we have 2 microscopes. So everything is given to you to work on. From 9 to 6, you are on to the work. Lunch कराऊंगा बीच में ऐसे बात नहीं है, but most of the time it is off the work.
Sir, I am a pediatric dentist. But
So we talk about open apex management, everything, apical plug formation. So we give you a map to work on how exactly, so that you get used to armamentarium. And then you can, whatever you like, you can add on to your practice.
I'm just trying to ask that you specifically train us in the microscope, or I am really interested in something which starts from the basic.
Ma'am, we give you basic to advanced, we give you every, that is my protocol.
Okay.
मतलब मैं ऐसा नहीं है कि अब आप मेरे पास 3 दिन के लिए होगा डॉक्टर प्रशांत मुझे ये करना है, तो मैं आपको कहूँगा मैम मेरा माइक्रोस्कोप यूज़ करो, क्योंकि एक्सपोजर तो लो, क्योंकि जब तक आप खुद नहीं करोगे, थोड़ा बहुत देखोगे नहीं तो नहीं हो सकता. सो आई एम नॉट अ पर्सन कि अच्छा माइक्रोस्कोप के लिए आप अलग से आना, उसके लिए मैम ना मेरे पास इतना टाइम है, ना मैं इतनी वो पैराफर्नेलिया पढ़ाता हूँ. I tell my doctors who come, sir has come, Rahul sir, he came for his program with me and he did it. So 3 days he was engrossed in that.
RDH में कब है अभी? RDH में?
Rajasthan में है मैम 11th को.
11th को.
That is,
PG from there.
because I was invited there on 11th. I'm invited for talk on bioceramic 1.5 hours. So I'll be focusing on more on the open apex and the large periapical lesions, what we have done. So entirely, and micro endo as well. So that is how it is. Yeah, 9971 71 61 5587 87. Just send me a hi at WhatsApp with the name so I can just send it to you. Chale, can we do it? Camera is there? Thank you so much, man. Pleasure here. Pleasure so much. Thank you. Just send me a hi with the name so it becomes, I can save it. Thank you so much. Thank you. आगे कैमरा. Just a saline, probably a bottle, and if you can have a small cup, yeah, maybe a rubber ball, वो ज़्यादा easy होगा तेरे लगाना. Anything, whichever you are comfortable. वो निकाल लेते हैं ना, एक ऑरिफाइस ओपनर दे दे मुझे, मैं सब बाहर ही रखूँगा, एक डिफाइंडर दे दे, कोई दे दे 10 नंबर एक। हमें क्या चाहिए सर, आपने बताना है, हम तो आपके लिए हैं, आप जो बोलोगे हम वो करेंगे।
हम तो जल्दी बुला रहे हैं आपको दोबारा।
कहाँ बुला रहे हो?
मैं भी कोटा और जोधपुर।
जोधपुर
या कोटा।
खोलिए।
फैब फर्स्ट, वो मैंने शिवम जी बोला था।
फैब फर्स्ट डेट क्या है? डेट बोलिए कोई।
डेट अभी कंफर्म नहीं करिए, पहले मैंने शिवम जी से कहा था,
क्योंकि मेरा ना आई हैव टू ट्रैवल टू दुबई फॉर हेडेक।
बताया था शिवम जी ने।
हाँ कि मेरा ना वहाँ लेक्चर है 3 दिन।
सेकंड में कर लेंगे। क्या डेट है आपकी दुबई की?
मैं हूँ वहाँ पे, आई विल बी फ्लाइंग ऑन 5th नाइट,
5th 6th 7th
5th 6th 7th 8th मैं वापस आऊँगा, फिर 11 को मैं हूँ सूरत।
ठीक है,
सूरत के बाद फिर कर सकते हैं, 11 के बाद थर्ड वीक।
ठीक है, तो एक बार शिवम जी को बोलूँगा, बात कर लेंगे।
डन,
डेट कंफर्म कर लेंगे।
वो लगाएंगे तो मैं करूँगा, मैं तो रेडी हूँ। ये कितने यूज़ कर लिए हैं आपने? कितने यूज़ कर लिए?
ये 0 1 तो ये इसलिए होता है, इसका क्या काम है? ये रोटरी के लिए
उसी के लिए है ज़्यादा।
इसको इधर ही कर देंगे, इसको इधर लगा, यही तो सही रहेगा। सर
पानी अभी नहीं, अब एक ही बार करेंगे काम।
बिल्कुल नहीं
ना जी ना, अभी काम में लगे हम। लेट्स फिनिश द वर्क फर्स्ट।
सर 1 मिनट इसको शिफ्ट कर।
हाँ जी, पूरा करिए आप।
इधर कर, आप जिधर बोलो, बट उधर वो हो जाएगी सेटिंग। हाँ, थोड़ा आ सकता है बस, उधर कर लें। डन डन, शेखर उठाओ।
मनी टीम में भी भेजा, मैंने कहा लाइव सेशन हो रहा है, देखो।
हाँ हाँ,
लिंक आ गया।
अच्छी बात है सर, जो आ जाए बढ़िया।
प्लेन वाटर
उसकी ना, सॉरी नॉट रिक्वायर्ड।
मैं प्लेन नहीं लूँगा, मैं मिक्स
तो मैं शाम को पिलाएंगे। विद सोडा
पानी नहीं पिएगा ऐसा। डिफाइंडर से उससे हो जाएगा, मुझे नया निकालना पड़ेगा।
किससे?
डिफाइंडर
वो पड़ा तो है, उसमें डिफाइंडर का नया निकाला है ना।
नहीं, निकाल
कर लेंगे यार, टेंशन ना लें, हम सब कर लेंगे। अब मैं इसमें नहीं करना, ये आप जो रजिस्टर कराया उनको तो मत करो यार। क्या टाइम लग रहा है?
वही लाइव करना है, लाइव है
चुके आप आ जाना।
यूट्यूब पे भी कर रहे हो, ये मैंने यहाँ पे उसकी वजह से माइक ऑन है आपका,
तो कोई बात नहीं,
बातें
कोई बात नहीं सर।
लाइव जा रही है वो यूट्यूब, उसके बाद उनका फोन आया अभी।
It's good, man. We are just trying to discuss and work it out how it will be.
शिवम जी कह रहे बंद करो, बंद करो।
Cleaning, editing. एक बार क्या ऐसे भी लेक्चर लेना तो वो कॉलर माइक लगा nothing in the whole thing. Vicky, you can come on this side just to be here around so that we can just have the system.
फोकस बिगड़ गई। क्या चाहिए?
Give me the endo motor, please.
अच्छा
Just settings कर लेना। Just give me the file. Put it at 5 each. इस पे रख लो 300 and 1 is that what we'll be needing it, and 1 you can put 500 and 3 rest off. Then I ask you, नहीं maybe you can change it here.
ठीक
Be
है, मैं
here.
यहीं हूँ।
That's okay.
अभी 300 में होनी चाहिए ना।
हाँ
और कोई K5 क्या चाहिए?
I'm just checking.
K5 चाहिए।
Just let me see. Maybe try to find it. Give me the block. So I think I need a mic to be here also, no? How they will listen. This mic will go on. Here. What I'll suggest, you take a chair and you sit with me. Okay, so welcome back.
इसके नीचे नीचे आएगा।
Fine. Okay. Okay. I hope I'm audible. I hope I'm audible, right? Okay, perfect. So like we have talked so much about the entire protocol for Rotary Endodontics, right? So after all the theoretical part and all the clinical case discussion, now it's our time to actually feel the system, right? Because as I always say that you need to really feel the system before you believe in it, right? So for that, we're going to do some small hands-on for you so that we can just showcase you what are the protocols, how we do a ZI, and how we can make our endodontic procedure more simpler, right? So we'll be showcasing you this thing on a block. So if you see here, this is the block which I have. So you will be also getting the same block in your hands-on, right? So it's a J-shaped kind of a canal that you see here. So the first step, what we say, is the orifice shaping. If I go with the basic protocol, I'll just repeat for you. First was the orifice shaper, and then we create the patency, right? That is a D finder or a glide finder, depending upon the canal, and followed by the 1304, that is a rotary glider, and then followed by 2504 and a 2506, depends upon the canal morphology and the width of the canal. Okay, so just 503. So if you see this file, this is the first file. Can you see this? Is it visible to you? No. It's hazy. Video is lagging. If you can come here now. So this is the first file, which is the orifice shaper, that is in my hand. Okay. Now, and the recommended speed, if you see on my endomotor, so you have to adjust the speed depending upon the files. Okay. So every file has a speed to work on. But in Zizai, the only speed and the torque you will going to change is only for the Zizai glider. Rest, all the files will work on the same speed and same torque. Okay. So this is the first file. This is 2514, what you see as an orifice shaper. Can you have a light here? A little bit. So 3 to 6 millimeters you should go. Can you appreciate the debris which is you can see? So again, as I said, the Zizai orifice shaper, it also has a radial line. So that means the safety starts from the beginning. Okay. So make sure that when you use the rotary files, when you collect a debris, always clean that debris before you introduce it again. That is very important because the flutes have to be cleaned of debris. It's not like that we keep using it. So once you have done the initial preparation, maybe we can have some tissue paper. Tissue, maybe. Yeah, thank you so much. So always clean your flutes. So I did with my orifice shaper, the first file which has been done. And then depending upon the canal, as what we have discussed, I took out the file. So you already have your working length with you, right? So this is the glide finder file. This is the glide finder file what we had been using, that you can see. It is another different type of file with the dual taper. That's what we said. So it has a taper of 3% from the tip up to 3 millimeters, that is 3.5. And then over and above to the shaft, it has a taper of 2%. So it's a dual taper file. So I will use it to create a glide path. Can we have a light little bit on this area? It's too dark. So always pre-curve. That's what we say. Pre-curving of file is very important when you are doing a glide path, because as I said, every canal is not straight. Okay. Now, sometimes what happens, where to pre-curve? Buccal, lingual, mesial, distal. Now that's very important. So the best way to do is, what you should do, you should always take a new file. That is very important. 10 number or a 15 number. It's always better to take a 10 number. Take a 10 number file, go watch wind and place it into the canal, the new file. Okay. And then you have a rubber stopper. Now this rubber stopper is actually your guiding path. Because on this rubber stopper, you will see there is a black mark, or you see there is a small projection which is come out, right? So now what you should always do, this projection or the black mark, you should keep onto the buccal surface. Go inside the canal, leave into the canal for about 10 to 15 seconds and wait. And then take out the file. So then you know that, okay, the mark is on the buccal. So now you should see where the file is curving. Opposite to it, mesial to it, distal to it. So that will help you to have a better scout that you know that, okay, where exactly the canal is curving in. So that way you can pre-curve your files. Okay, so we'll take this thing and we go. Again, watch winding is the motion that you have to use, and push and pull till you reach to your working length. A little bit of circumferential filing is always very important. Now you should do it till you feel that in the canal the file is only binding at the apex, and rest of the areas it should be free. That means you are ready to go with the rotaries. Now once that is done, irrigation is the key. Make sure your needles, as I said, perfect. So side vented needle 30 gauge, especially when you have moved inside the root canals. Okay. Keep irrigating in between. That is very important, because when you have debris, then you have lot of blocking of the canals. Now once that is done, then I have created a glide path. Now I will introduce my first rotary file, that is a Zizai glider. So if you see here, it is a 3 files, what you can see in this pack. We have 1304, then we have 2504, and we have 2506. So as I said, so Zizai glider is a very important file for your 2504 and 2506 to move smoothly inside those root canals, right? So you have to use glider very nicely and comfortably. So again, the recommended speed is 300 RPMs and the torque is 1. You can vary the speed depending upon the canal morphology, right? So it has to go in a single length. That is the key. It's not like that you will be going in thirds. Generally, what exactly? So this instrument has to be used in a one go. Okay. So if you see here, my motion is single length. And you keep scraping it towards along with the walls. Again, we go back to our irrigation, activation, warming will always be there. That is very important, right? Now, once this is 1304, the preparation is done. That is, the glider has done his work. Now, which they are the mesial canals. Just change that. 503. Now, this is my 2504. The file 2504, right? And the speed is 503. So please make sure that you maintain the length every time. So your reference point and everything should be very clear. So let me just take that. So the light is a bit less here. So here what I am taking is the inner part of the apex, the round part I am taking as apex. Okay. So again 503, and we go. So as you go a little bit, slide, retrieve, and then you can go in. Because when you're using in a tooth, you will be using with EDTA. Okay. So just single length, and here you go. This takes, it's because it has a canal centering ability. This is the advantage of this file, yeah. Which one? Beta, you have that down pack system for it. Like how we do thermoplastic condensation of the gutta percha. So you have a down pack and one you have a backfill. So it comes as a vertical heating tip. It's like this kind of an instrument, right? In which you can set up the temperature to 180 and then you put that tip, fill the chamber and place it there. You can't do it. Okay, so this is 2504. Again irrigation, because now one thing which I want to show you here. We talk about the flexibility of this system, right? So this is the file. Just wait, I need to show you more. What else you need in a file to work mode? So these are heat treated files. So the best part is that once it goes into the autoclave, they regain its shape. Okay. Now another thing what you need to do, you need to autoclave your files. That is very important. Okay. Once you have done a procedure, autoclave them. Now how will you know about these files that when you are supposed to discard? Correct. Now as I said, you have a radial land, right? So once you will autoclave these files, when they come out of the autoclave, just see the radial land that it is of the same shape. If the radial land is elongated, please discard. So that means you come to know initially itself that the file is done its job.
So roughly how many canals can be used with this file?
See, if with the Zizai glider, that's I always say that the glider is the first file. Now if you are working in a very calcified canal, very curved canal, then after 2 molars you should discard the glider. It's always better. You should not wait for it to fract. But yes, if we talk about say Zizai 2504 and 2506, you can work up to say up to 5 molars. That means somewhere around 15 canals. So it's good enough that you can work more. But yes, these files are very steady files, very good files. But I always emphasize that a glider should always be more incorporated, initially well prepared, so that the Zizai flows very well. And that's very important with Zizai, right? So this was 2504. And then let me prepare to 2506. Now, just open 2506. So this is 04 file, so I was able to show you the flexibility and of the file. Now, as we all know that when the taper increases, what happens to a file? What happens to a file when the taper increases? It becomes what? Flexible or rigid? So this is 2506. Just wait. 06. So you give us the canal anatomy, we have something to put in, which works very comfortably. And any shape, it will take up once it moves inside the root canal system, right? So again, the recommended speed is what? What is the recommended speed for Zizai? 500 rpm. I'm so happy. Thank you for so that is 2506, single lane, and I'm done. Sorry? 06. Now if we compare both of them, I just show you a block which is unprepared and I show you a block which is prepared. If you can see on the screen, actually there is a bit of lag, okay. But if you see, it maintains the same anatomy because that is how you can compare it. A canal before preparation and canal after preparation. And then you take the corresponding gutta percha and you may place it there and you can seal it. And you are done. Okay. You have the GP? Gutta perchas. If you, हाँ.
6 और 4 दोनों.
दोनों दे दो. कौन सा prepared है? बहुत कम है. It's very difficult to. हो गई. Just give me the GP and we are through. We can just 5 more minutes and we can. So if you have any questions, I can take it up and then we can. I hope the system is clear. Any other thing which you, once you do the hands-on, you are registered for the hands-on, all of you, right? Yes. So I think that will be the better time where we can have a more discussion on the system, right? So I think we are good to go. Yes. Thank you once again.
Thank you, sir. Thank you so much. Now I request all the delegates to head for the lunch in the LD1.
Okay. And what time we are joining back for hands-on?
And
2
at
o'clock?
2 we are going to join back. Not here, but in the second floor, department 7, for the hands-on.
Okay. So have your lunch fast and let's join at 2. Because let's use the time of hands-on.